Good morning, everyone, and welcome to our second meeting of the Joint Interim Standing Committee on Health and Human Services for the 2023-2024 interim. Madam Secretary, please proceed to call the roll.
Senator Nguyen?
Here.
Senator Titus?
Here.
Assemblywoman Brown-May?
Here.
Assemblyman Gray? Assemblyman Hibbets?
Here.
Assemblyman Nguyen?
Here.
Assemblyman Orentlicker?
Here.
Chair Donyate?
And I am here. And then please mark Assemblyman Gray present when he arrives. Welcome, everyone, to our second meeting. It's an honor to be here with all of you today. I apologize for scheduling a meeting on spring break. I know that many of us have kids, and so I apologize for that, but hopefully today will be a good and eventful meeting. Today marks the second meeting, of course, of the Joint Interim, and as you may have noticed on our agenda, we have a lot of good presentations. During our first meeting, we mentioned that the committee was going to have several discussions on the different priority areas that we would be focusing on, and today's theme is access to care. Many of the conversations that we'll have today deal with access to care, and so for those that are coming for public comment, these are the points that perhaps you would be looking to emphasize, of course, and then hopefully by the end of the day, we can start to have policy discussions on what we can do to improve access to care in the state. I do have a few just remarks in general, just for folks who are willing to participate. First, I would like to remind everyone to please silence any electronic devices, both here in Las Vegas and in Carson City. For members that are joining online, please mute your microphone when you are not speaking, but you can leave your camera on. Additionally, I ask our presenters on the Zoom video call to leave your cameras off and microphones muted until I call up the agenda item under which you will present. The Zoom video call has a chat feature. However, this feature is only to be used for technical assistance. And agenda items may be taken in a different order than listed, or two or more agenda items may be combined for consideration. The committee's meeting materials can be found on the Nevada Legislature's website, and you can also sign up for the electronic notifications related to the activity on the committee's website. And if you wish to testify here in person, either in Las Vegas or in Carson City or online, you can sign in at the table by the door and leave a business card. And if you do not wish to testify, you may also want to sign in so that we can have a record of who's here and participating. When testifying in person, please turn on the microphone on to speak and off to listen, because we have others listening to and viewing the meeting both in Las Vegas and online. And with that, we will go ahead and open public comment. So if anyone is interested, please go ahead and make your way to the front of the room. And we'll start here in Southern Nevada, and then we'll go to Carson City right after. And you may begin when you're ready.
Good morning, Chair Donyate and members of the committee. My name is Jamelle Nance, that is Jamellellenance, and I'm the Early Childhood Policy Director with the Children's Advocacy Alliance. I just wanted to say how grateful I was to see childcare and housing on the agenda for the presentation with the NCSL, and just offer a few highlights and things to consider. Right now, currently, we have seen significant investments over the years due to COVID, but we're currently serving about 10% of infants and toddlers in the state. And so I want to just say that we attribute this to our continued childcare desert that is impacted by low wages and reimbursement rates that do not truly reflect the true cost of care. Our ARP funds did provide some much needed relief. However, there is a looming fiscal cliff that we want to mention that's happening at the end of September that will place many child care providers back where they started if the necessary support is not secured. I want to further acknowledge the promising new updates to the CCDF. However, we know that without the proper infrastructure, we will not be able to see the full benefits that the updates offer. For example, one of the updates includes expanding childcare choices for families that meet their needs. However, we continue to face significant hurdles with expanding home-based childcare due to HOA and zoning regulations. The systemic issue we face cannot be remedied with funding alone. It is important for Nevada to have a governance structure that supports a comprehensive early childhood system to ensure that we meet the needs of the whole child. And we have to continue to challenge these systemic barriers, including affordable, stable housing. According to our partners at Schoolhouse Connections, there were an estimated 6,825 children experiencing homelessness between the ages of 0 and 3. And so we just want to emphasize that children need stable housing to best support their physical, social, and emotional development to ensure they enter school ready to learn. Thank you for your continued support, and we ensure that we'll continue to keep early childhood top of mind in the state.
Good morning. My name is Dan Musgrove. Good morning, Mr. Chair, members of the committee. I'm here today on behalf of U.S. Anesthesia Partners. I'm speaking on regards to item number 7 regarding consolidation. I just wanted to make sure that you had an opportunity to think about a few things as you listen to that presentation, because there's a number of remarks about U.S. Anesthesia Partners in the PowerPoint that's provided by the culinary. And I just wanted to make sure that there was some thoughts that you had in your head as you hear their presentation, because again, I'm not sure what they're going to be saying. But you know, Nevada is very, very unique. And U.S. Anesthesia Partners is one of the very few anesthesia groups where the bulk of their business is Medicaid. They treat 60% of the Medicaid patients in the state of Nevada. And let me put that in perspective, because if you know, and I think those of you who have been on these committees before and even on Ways and Means and Finance understand that reimbursement rates when it comes to government programs are very, very lean. In fact, anesthesia has not had an increase since 1991. In fact, they had a dramatic decrease in 2010 of 43% of their Medicaid and Medicare rates. In fact, we just got notification today that Medicare is going to be reducing rates again. So when you think about consolidation, you want to think about the services that we have to provide in a very, very lean market. Right today and every day this week and every day after that, 18 of our physicians are on call every day, 7 days a week, 365, because of short of anesthesiologists. Why? Because Nevada is not an attractive market when it comes to reimbursement rates. Factor in the fact that we just doubled our malpractice insurance. Again, why would people want to come to Nevada? And so U.S. Anesthesia Partner works harder than anybody to try to bring people to Las Vegas and to service those that need anesthesia services. We provide the only residency program in the state of Nevada through U.S. Anesthesia Partners. We work with nurse anesthetists, the CRNAs, to make sure that they get training so that we can, again, provide the coverage that is sorely needed in this valley. There's a couple discussion of some lawsuits in Texas and in Colorado. I can tell you that neither one of those, the Texas has not been resolved. The Colorado issue was settled into the agreement of both parties, but again, no claims by either party have gone to court.
Mr. Musgrove, if you can complete your comment, please.
Absolutely. Anyway, I just wanted to have you think about those things as you listen to consolidation. It's very important to provide infrastructure for these doctors, because they need to be serving patients and not worrying about the back end of the house. And the worst thing that we have is chasing payments. So thank you for the opportunity. We would welcome the opportunity to talk about U.S. Anesthesia Partners with you individually or during a subsequent hearing. So thank you for this opportunity.
Thank you so much. Anyone else in Southern Nevada? Let's move to Carson City. Is there anyone in Carson City?
Good morning, Mr. Chairman. My name is Tom Clark. I'm here on behalf of the Children's Cabinet and the United Way of the Northern Nevada and the Sierra. Here on item number 6 on your agenda. Like your previous speaker, I'm excited to see that child care is an issue that's going to be discussed during this interim. We are the leaders in this arena, the Children's Cabinet is, and we look forward to this presentation today, as well as respectfully request that the Children's Cabinet and our other stakeholders have an opportunity on a future agenda to discuss how these impacts are really happening in child care and early childhood learning here in the state. Thank you, Mr. Chair.
Good morning, Chair, members of the committee. My name is Cindy Green, and I am the EMS Chief for the Reno Fire Department. I'm here on behalf of Dave Cochran, the Reno Fire Chief, and also the President of the Nevada Fire Chiefs Association. I'm specifically speaking to item number 11. You're going to see their presentation this afternoon. The need for increased investment in the state EMS program is vital, and it is important to the Reno Fire Department. Over 60% of the calls that we run, and receive are for medical treatment. And each of our 300 first responders carry an EMS license to practice medical care. Each year, the Reno Fire Department must renew a permit to provide EMS services in Washoe County. We recertify approximately 150 EMS personnel. We request inspections of our fleet of EMS vehicles, and we report data related to the medical calls that we run. The state EMS program is currently understaffed and under-resourced. They have been unable to fill positions that are open and available. They're currently sitting at a 50% vacancy rate. Currently, just 3 program representatives serve the entire state, excluding Clark County, and are responsible for the oversight of licensure for 6,000 to 7,000 providers. These vacancies have led to long wait times in our service requests and a delay in our ability to provide emergency medical services to our communities. If something does not change, there is a real, very real possibility of a catastrophic outcome that would compromise safety and the livelihood of our Nevadans. Looking forward, one solution would be to change the EMS program to a Bureau of Emergency Medical Services. We understand that this would allow for a reclassification of the existing 8 positions, which we believe would increase the state's ability to recruit and retain these essential workers. Thank you for your time today, and I look forward to seeing what the committee is able to accomplish in the interim and the next legislative session.
Dr. Dale Carrison, for the record, Chairman of Nevada's EMS Advisory Committee. I'm the former head of Nevada's Homeland Security Commission for 7 years in 3 governments. I've been involved in EMS services in the state of Nevada for the last 30 years. I'm speaking to item 11. I could speak to item 5. I initiated the first emergency medicine residency in the state of Nevada. We're here today because of multiple issues concerning the support for the division that Ms. Sullivan is in charge of. I think people forget what the importance of calling 911 is. When you call 911, who's going to show up? You're going to have an EMT, you're going to have an advanced EMT, or you're going to have a paramedic. And without that support, we don't have that. All of you may be familiar with the recent article showing that Nevada is an ambulance desert. I find that highly concerning for the state that I have adopted. I was at UMC for almost 30 years, and now I'm currently in Current, Nevada, and I'm also the Associate Medical Director for East Fork Fire in Douglas County. So this issues that are going to be presented to you today with regard to EMS are incredibly important to our state. But Nevada revised statutes eliminates Clark County from this consideration, so now we are in northern Nevada and everything outside of Clark County trying to have the resources necessary to provide emergency medical services in this other parts of the state of Nevada outside Clark County. And it is an ambulance desert, and the support of this body and the state is incredibly important so that we can get rid of the title of ambulance desert, which I find highly offending for the state of Nevada. We need the paramedic education. We have involved. There are 3, REMSA, the Reno Emergency Medical Services, is currently having a paramedic class. Unfortunately, Western Nevada canceled their paramedic class, and I don't know why the Board of Regents allowed that, but we need more paramedics. I'm in contact with the paramedic education programs in Las Vegas. Right now, they have a class of 60 paramedics, which we would desperately need in rural Nevada and the other sides outside of Clark County. So I thank you for your time and would definitely appreciate your support of representing my committee members, which is all the fire departments in this part and the other individuals that are involved in EMS education and providing ambulance services in rural Nevada. Thank you.
Good morning. On behalf of the Alzheimer's Association, Benjamin Challenor, Director of Public Policy here in Nevada. We thank the opportunity to be able to speak in support of the American Cancer Society's proposal on expanding biomarker coverage. The Alzheimer's Association is the largest voluntary health organization in Alzheimer's and dementia care, support and research, and in addition to the largest Alzheimer's advocacy organization in the world, which is why we're here in support. There are currently over 49,000 Nevadans over the age of 65 or older living with the Alzheimer's disease or dementia, but as many as half of them are not formally diagnosed. An early and accurate diagnosis of Alzheimer's can improve access to care and supportive services, enhance quality of life, and reduce the financial impact of the disease. With the historic approval of treatments that slow the progression of the disease, early detection and diagnosis of Alzheimer's are even more critical to ensure individuals receive the most benefit at the earliest point possible in the disease progression. Currently, diagnosis of Alzheimer's disease relies largely on documenting cognitive decline, at which point Alzheimer's has already caused severe brain damage. Experts believe that biomarkers offer one of the most promising paths to improve dementia detection, diagnosis, and treatment. By expanding biomarker coverage, we not only save lives, but we can make sure that we save the state money. Thank you.
Good morning. I'm Julie Ellsworth. For the record, I'm Academic Dean over Allied Health and Public Safety at Truckee Meadows Community College. I was actually here for item number 10, but I did want to, being over the paramedic program at TMCC, just make a couple of words regarding the need for the changes that will be presented in item 11. And so the paramedic program, we have difficulty finding internship placements because there is such a lack of trained personnel. They're doing double and triple overtimes, and so the need to train new paramedics is hampered in and of itself by not being able to have internship training and to be able to pipeline the number of students that we need in that workforce to serve our community. Thank you.
Anyone else in Carson City for public comment? BPS, is there anyone virtually?
Yes, Chair. If you would like to participate in public comment, please press *9 now to take your place in the queue.
Good morning, Chair Donate, Vice Chair Ortlicker, and members. Kent Irvin, ERVIN, for the Nevada Faculty Alliance, the independent statewide association of professional employees at Nevada's public colleges and universities. In Agenda Item 9, the UNLV and UNR medical schools are providing information. We appreciate that the two med schools are working together. Nevada is served best when the rivalry between the two comprehensive universities is kept to athletics. Item 9B provides statistics on graduate medical education. Attracting medical students to residencies in Nevada is the first step in recruiting them to stay and practice in Nevada as physicians. But the quality of the educational experience is also important in making residents want to stay in Nevada. How are the two med schools working to meet national accreditation standards for resident training? More importantly, what are they doing to enhance the educational experience? Using more community-based medical partners in residencies means that greater oversight is needed. Ideally, these programs can develop residencies into longer-term professional relationships in Nevada, or else residents can be seen by private partners as cheap labor to maximize profits. So how are the med schools monitoring residencies in the field to ensure proper clinical supervision, high-quality education, and humane working conditions? How is state funding being dedicated toward those goals? Item 10 considers nursing education. The COLAs approved by the last legislature were a historic step in improving state employees' salaries across the board, but nursing faculty salaries have been especially far short of being competitive. How are the colleges and universities addressing nursing faculty salaries to increase the nursing pipeline and access to care in Nevada? Thank you.
Thank you, Chair, members of the committee. My name is Adam Zarin, that's Z-A-R-R-I-N, and I'm the Director of State Government Affairs for the Leukemia and Lymphoma Society. Our mission is to cure blood cancers and improve the quality of life for patients and their families. Last week, LLS published a new report entitled Healthcare Consolidation is Raising Prices and Jeopardizing Cancer Care Policy Recommendations. I've submitted that report for the record as you discuss item 7. In short, a few large hospital systems are increasingly purchasing local healthcare systems, hospitals, and doctors' offices. Those big health systems are gaining more control of their markets, leaving insurers and employers with less leverage to negotiate lower costs. These increased costs are passed on to consumers through higher premiums, out-of-pocket costs, and even lower wages. This means patients are less able to afford the care they need and are more likely to delay or even forego treatment. These are well-researched and documented facts about our healthcare system. The research also shows that consolidation, particularly hospital mergers, is especially harmful to Black, Hispanic, Indigenous, low-income, and LGBTQ+ communities, as well as other people of color and women. Mergers among healthcare providers often lead to fewer services offered, leaving people in marginalized and disenfranchised communities with fewer options for where to receive certain types of care. So what can policymakers do? Our report outlines recommendations for policymakers that strengthen antitrust enforcement, reform pricing and reimbursement rules, prohibit anti-competitive contracting terms, and improve transparency standards. We appreciate this opportunity to share this information with the committee and look forward to future conversations to address healthcare affordability. Thank you.
Caller with the last 3 digits of 046, please press *6 to unmute yourself. Again, caller with the last 3 digits of 046, please press *6 to unmute yourself. You are unmuted. Please continue.
Hello, my name is Chris McCann. That's M-C-H-A-N. I'm EMS Chief for Elko County Ambulance Service in Elko, Nevada. We cover largely portions of Elko County and collaborate with those who serve within our county to provide services throughout the rest of the county. I wish to speak to item 11. I'm excited to see that this item is on the agenda today to discuss the state of our EMS office here in Nevada. One thing I've noticed as I've interacted with many other agency leaders throughout the nation is that our EMS office is pared down compared to many other states. And to give you an example, in our EMS office, they're charged with helping regulate things like trauma centers. In other states, that is commonly a sole job or even a program or an office of their own that runs something like that. And our EMS office has several of those assignments that they carry within their office, in addition to the regulations of ambulance services. I'm excited to see that we're talking about this and helping give them some more support. I know from personal experience several years ago, I looked at becoming an employee of the state and working in the EMS office, but it would have been a significant pay cut for me. I was making about double what the application was at, or the position was advertised for. That seems like a challenge for our EMS office to be able to recruit and retain staff when those that are equivalently qualified in agencies are paid significantly more to be able to work in the EMS industry. I'd like to see for an opportunity for our EMS office to receive more funding and support to be able to meet some of their objectives and their authorities and be able to regulate where they need to. As they struggle with recruitment, has been mentioned in previous testimony, they have a large gap which slows down the credentialing of ambulance agencies and of personnel. It's something we need to address within our state to make sure that we have continued EMS services here in Nevada. Thank you for your time.
Chair, you have no more callers at this time.
Thank you so much. We'll go ahead and close public comment, and we'll move on to the next agenda item. Agenda item 3, approval of minutes for the meeting on February 16, 2024. So just for clarification, the February minutes are not ready for approval, so we'll go ahead and just skip this item. So just wanted to make sure that that was for the public's input. We will go ahead and move on to agenda item 4, consideration of regulations proposed or adopted by certain licensing boards pursuant to NRS 439B. For this agenda item, I will go ahead and let Mr. Robbins go ahead and review the different regulations, and then afterwards, similar to last meeting, I'll open it up for the committee members if they want to pull any particular regulation so that we can have a discussion on them, then we can pull them out, and then we'll go with any questions or discussions. So let's go ahead with Mr. Robbins.
Eric Robbins, LCB Legal, for the record. We have 5 regulations for the consideration of the committee today. LCB file RO72-22 of the Board of Dental Examiners, R125-23 of the Board of Examiners for Marriage and Family Therapists and Clinical Professional Counselors, R068-23 of the Board of Medical Examiners, R095-23 of the Board of Psychological Examiners, and R108-23 of the Speech Language Pathology, Audiology, and Hearing Aid Dispensing Board. And those are our regs.
Thank you so much, Mr. Robbins. For committee members, is there anyone in particular that you would like to pull out? So I don't know if we have anyone down here in Southern Nevada, anyone in Northern Nevada. I don't think we have any questions, so we should be good. Just for clarification, if you see something and you want to bring it back to our attention, we can always communicate offline to the different boards. So we'll go ahead and continue on with our next agenda item. Thank you so much, Mr. Robbins. Next, we will go ahead and start with presentation. Item number 5, presentation on graduate medical education funding implementation update on Senate Bill 350. And policy considerations. With us, we have Director Mitchell from the Governor's Office of Science, Innovation, and Technology. So please begin when you are ready.
Good morning, Mr. Chair and members of the committee. I'm Brian Mitchell, the Director of the Office of Science, Innovation, and Technology, or OSIT. Happy Daylight Savings Time to those who celebrate. And I am very pleased to be here today to provide an overview of the Graduate Medical Education Grant Program that OSIT administers. Today I was requested to talk a little bit about how GME funding is allocated, an update on SB 53 implementation, and then also any policy considerations for the committee, after which I'll be happy to take any questions. First thing I'd like to talk a little bit about is as I bring greetings from the governor and the governor's office, and the desire to communicate to the legislature the governor's strong commitment and support for the graduate medical education grant programs of the state. The governor recently outlined a number of different policy priorities to state agencies, and those of us at OSIT were very pleased to see that graduate medical education was included in the policy matrix as a specific policy that the governor has called out that he wants state agencies to focus on. So this is a priority for the governor. This is something that he believes is very important, and is looking forward to working with and collaborating with you all on the graduate medical education program. Just very briefly, I think it might be helpful to just for clarification, to talk a little bit about what graduate medical education is and the current state of graduate medical education in Nevada. So, following the completion of medical education, for example, either at the UNLV or the UNR schools of medicine, doctors must complete a residency program in order to practice medicine. Without graduate medical education, or GME, physicians cannot become board certified and obtain a license. GME programs, the length of GME programs depends on the specialty and may last as few as 2 years and as many as 5 years. Residencies are where physicians become specialists, such as in pediatrics, family medicine, psychiatry, internal medicine, etc. For more complex medicine, residents may pursue a fellowship or a subspecialty, such as cardiology or neurology. And fellowships can last an additional 1 to 3 years beyond the residency. And some subspecialties require multiple fellowships. I appreciate some of the public comments, that talk about the various deserts that we have in Nevada. And I think, physicians in many subspecialties and specialties throughout Nevada and in different regions of the state certainly qualify. Nevada consistently ranks as one of the most underserved states in most areas of healthcare delivery, both in urban settings as well as rural settings, and due in large part to a shortage of physicians. Additionally, many graduates of Nevada's medical schools must leave the state if they want to seek a GME specialty, since Nevada lacks many specialties and subspecialties, and also Nevada produces more undergraduate medical students than it has residencies available or fellowships. According to the Nevada Workforce Research Center at the UNR School of Medicine, recently about 40% of physicians graduating from GME programs in Nevada plan to remain in Nevada to begin their clinical practice or pursue further trainings. In contrast, 33% plan to leave the state to begin clinical practice elsewhere, and 26% planned to continue training outside of the state in programs that don't exist in Nevada. So that's about 60% plan to leave the state in total. Over the last decade or so, retention rates of graduating physicians that plan to begin clinical practice have varied from a high of about 48% down to a low of about 25%. And so overall, the numbers speak to the need that we have in the state to do more to retain the physicians that graduate here and more to attract ones from elsewhere. So I'd like to talk a little bit about the current GME grant program and how that helps increase both the raw numbers of physicians remaining in Nevada, as well as those coming from outside of Nevada, by increasing the numbers of residencies and fellowships. The current program also provides the opportunity to retain more physicians in Nevada who plan to continue their training, given that many of them leave for training programs that don't or that haven't historically existed here. So, when I speak about collaboration on graduate medical education, we have a long history in this state of collaborating together, the governor's office and the legislature. The graduate medical education grant program was first funded in 2015, which was also the year that OSIT was created. And so the graduate medical education program was assigned to OSIT upon its creation. And having worked at OSIT since 2015, I in many ways feel like GME is it's a program I'm very passionate about and consider it very very important to me personally. Since we awarded the first grants in 2016, we've made 28 awards. Those 28 awards have a combined capacity of, or a number of slots between them of about 160 fellowships and residencies, and we've awarded about $28.5 million. I want to talk a little bit about kind of the process for awarding funding for these programs. So the first step involves a lot of preparation and consultation with data, and particularly looking at the areas that are health profession shortage areas when it comes specifically to physician practice. When we first started the GME grant program, we focused exclusively on family medicine and mental health. Those were the two eligible specialties for the first several rounds of funding. Since then, we've expanded the eligible specialty and subspecialty set to include any specialty or subspecialty where Nevada or where the region in Nevada ranks below the national average for that particular specialty or subspecialty. There are places in Nevada, for example, there may be a certain specialty where we're above the national average in the north and below the national average in the south. So programs in the south would be able to apply for funding for that particular specialty or subspecialty. I want to take a moment to thank Dr. John Packham at the Office of Statewide Initiatives at the UNR School of Medicine. He is an amazing resource for all sorts of data when it comes to physician practice in the state. The program structure, we award funding or funding is the eligible entities that can apply for funding as any ACGME accredited entity. ACGME is the accrediting body for graduate medical education programs across the country. There are we allow for either new programs, so a new subspecialty or subspecialty who wants to get started, or a program that has a waiting list for the specialty or subspecialty to expand the number of slots that they have available. For example, maybe to go from 4 slots to 8 slots. The program allows for any expenses that are related to the startup of a new grant program, and I'll go through some of those here in a minute. Typically, these programs take about 4 to 5 years total to ramp up. It's quite an extended length of time, and I'll go into some details there in a minute. The programs themselves, typically what we will ask for in the request for proposals is a budget narrative and a plan, and then a project narrative that consists of a needs assessment, so using data to show that the need exists and that it's a particularly acute need for the particular residency or fellowship program. A feasibility assessment that discusses the institution's ability to carry out the program, and then a work plan that details how the applicant will go about achieving accreditation and then carrying out the proposed project. We ask for a sustainability plan, how the program or how the sponsoring institution, whether it's a medical school or a hospital, will be able to sustain the program over time, and an accounting of what the ongoing costs of the program are, and then finally, how the program will collect data and evaluate their success, including contributing data to Dr. Packham at UNR. And then the final thing is a certification of accreditation that they have to show us. The evaluation process, OSIT assembles an evaluation team of individuals with expertise in graduate medical education and that don't have a financial interest in any of the proposals that are being proposed. And we have a scoring rubric wherein the proposals are evaluated and then funding decisions are made. I mentioned that we have, over the years, we've funded 28 different programs, and I just wanted to provide a kind of a snapshot of some of the specialties and subspecialties that where Nevada is below the national average in the number of physicians per capita. And these are some of the different programs that we've funded. So psychiatry and behavioral health, primary care, OBGYN, internal medicine, geriatrics, family and community medicine, physical medicine, rehabilitation, surgery, pediatric emergency medicine, pulmonary and critical care surgery, forensic psychiatry, radiology, preventative medicine, pediatrics, hematology and medical oncology, and rheumatology. We've funded grants in the north and in the south. Medical schools in the state have been successful applicants, along with individual hospitals. And then we've also funded grants where there are rural tracks or rural components of the training. So a physician may start out, or a resident may start out in an urban setting and then spend a few years of the fellowship or the residency practicing in a rural area before wrapping things up, back in the home base. All right, on to SB 350 implementation. Our implementation of SB 350 has certainly not gone as quickly as we had hoped or expected. When SB 350 first came into being, we identified that separately from the passage of SB 350, the governor proposed and the legislature funded the hiring of a new staff person that would be wholly dedicated to the funding of the GME program. As the GME grant program has grown over time, the need to monitor and continue to follow up with previous grantees, as well as have a new grant program and administer that, became too much, and so we needed to hire a new staff person in order to make this grant program continue to be successful. And then we identified a 6-month plan that we would onboard the new person and begin to implement SB 350. In the 14 years that I've been a state employee or worked in various capacities for the state, I've never had a more tough time hiring a person. It's been quite the difficult process, and we're still this is something that we're still working on. I want to give you kind of an idea of the type of person that we're looking for, and that we're advertising for. So the candidate needs to have the ability to do program strategic direction, budgeting, and be able to do budgeting and projections, stakeholder engagement, particularly director level engagement with key stakeholders at the medical associations, at the medical schools, hospital CEOs, the Nevada Hospital Association, DHHS, and so on. This individual needs to be able to do program implementation, including the oversight and management of the competitive GME requests for applications process, organizing a review committee, writing the grant agreements and executing awards, and then doing all of the grant management and follow-up to ensure that the costs that are expended are eligible for reimbursement. Monitoring and oversight, including the post-award fiscal and programmatic compliance reviews, and then finally administrative and regulatory work related to overseeing the process, open meeting law, and other meetings that including agendas, minutes that need to be taken care of. So we're still having some conversations internally with state HR and hope to be able to resolve that soon. We're in the middle of a recruitment now, and hope to be able to start interviewing some candidates very soon. Once this person is brought on board, we have a 6-month plan that will allow for the person to get up to speed in what GME is and go. It includes a significant amount of stakeholder engagement to previous awardees as well as eligible entities. that can apply for grants and then would be able to begin putting together a 5-year strategic plan for graduate medical education and to be able to present that to the committee that has been identified in SB 350. The committee also asked for some policy considerations, and the one that I would like to bring forward to the committee today, this policy consideration may be a better fit for the budget committees, but given your role in improving healthcare access, I want to mention it briefly here today. So. A new graduate medical education grant program, as the folks in the room who have been recipients of funding know, typically takes 2 to 4 years, and sometimes even longer in some cases to create and to successfully launch. The creation of a new GME residency or fellowship requires adherence to externally mandated timelines that don't always easily align with the state fiscal year or a biennium. So, for example, accreditation bodies only meet a few times a year, and accreditation is needed in order to move forward with some aspects of the program that we funded or some aspects of creating a new residency program. So, for example, if there is a delay in hiring a program director, that could cause a program to miss an accreditation window, and that could cause a delay for 6 months. Sometimes there are, when a program seeks accreditation, they need to make revisions to the program in order to receive accreditation, and that can cause delays as well. If a program receives an accreditation in the springtime, the program will not onboard residents for a full 15 months because resident recruitment begins in the early fall, and residents start the following July. So, these things take time to build, and if we've awarded funding in one fiscal year, we need to be able to map out and project out what those costs will be to creating the program. We had conversations during the last legislature around being able to balance forward unspent funding from the GME grant program that had been obligated to a particular grantee to allow for that program to be able to meet its accreditation timelines and be able to grow over time. Something happened where I guess it didn't make it into the final legislative language, so that's something that we'll be bringing back up again during this upcoming legislative session, is the ability to balance forward beyond the biennium dollar amounts that we've obligated to certain grantees. And what that'll allow us to do is to be able to have a dedicated amount of money, which will allow for more surety for the grantees that their funding, if they embark on a program, will be there in subsequent years in order to fully build out their program, even if there's an unforeseen delay. So with that, Mr. Chair, I appreciate you allowing me to be here and also accommodating my schedule today, and I'm happy to take any questions that the committee may have.
Thank you so much. Let's go ahead and proceed with questions from committee members at this time. Do we have anyone in Southern Nevada? Senator Nguyen.
Hi there. I have some questions, and it might be better for one of our next presenters. So if you're presenting from the medical schools, you might be able to be in a better place to answer this. I know that we haven't had much changes to, at least federal GME funding since, I think, the mid-90s. And with that being considered, I know that there's been proposals or talk about supplanting state funds into some of these GME programming. Do you know how many how many residency programs or spots there are in our state currently? Do you know that?
Mr. Chair, through you to Assemblywoman Nguyen, Brian Mitchell for the record. I don't know the total number of residency spots that are created, but But you are right that, first of all, the medical schools will be better at answering this question than me. But secondly, that Congress hasn't increased the amount of federal funding for GME for many years. And in fact, the formula was first introduced back when the East Coast states had a significantly higher population or proportion of the population than they do now, and so it's a bit of a sore spot, I think, for us in the West that are still growing. That we're kind of stuck with a much smaller amount of funding than perhaps we need.
Again, probably better answered by the next presenters, but I'll put it out there just so if there's some information they can find out. I'm curious on what the percentage of the residency programs are housed in private hospitals, because even if we were to have an influx or more money that went to these programs, you still need those facilities to create those programs, and how you would do so to, I guess, fill in those deficiencies rather than just create more existing residency spots we're just deficient across the board. So I just have some concerns about that. So, yeah. And then I guess my other question is, currently this program is housed within OSET. Like, I know in other states it's housed within like HHS or DHHS. Do you see any benefit to why it remains where it is now as opposed to moving into a more healthcare related space?
Thank you for the question. Brian Mitchell for the record. When OSET was created, OSET serves as both the state science, technology, engineering, and mathematics, or STEM office, as well as the state broadband office. And graduate medical education was viewed as a part of at the time, the governor's broader STEM education and workforce development initiative. And so the funding was sent to OSET. I think we've been very successful over the years in managing and working collaboratively with the Department of Health and Human Services. The folks from DHHS sit on our review committees and provide information and expertise into the the selection of which specialties and subspecialties are eligible in the design of the request for applications process. I think we have being a smaller agency, I think we have the ability to turn on a dime and be a little bit more nimble than perhaps some of the larger agencies, and so that works to our advantage. I also am not aware that that anyone necessarily in DHHS has spare capacity, and so moving it to another agency, it's I don't know that they have without appropriate staffing resources would be able to take on a program like this.
Any other questions in Southern Nevada? Assemblywoman Brown-May.
Thank you, Chair. Thank you, Mr. Mitchell. If you don't mind, I'm just going to follow up on that questioning, right? Not to suggest that OSET is not doing a good job at managing the program. In your testimony, you noted that your division has been slow to ramp up GME. And in many of the conversations we're having here, particularly in Southern Nevada, those slots are essential, right? We have the funding for them. And I'm just curious to know, is it helpful to grow your partnership with HHS in order to move this a little bit more quickly, in order to deploy those programs? Do you have any recommendation for how we can help you execute quicker?
Thank you, Assemblywoman Brown-May, for the question. Brian Mitchell for the answer, or Brian Mitchell with an answer for the record. I think perhaps the most important thing for us would be to be able to balance forward funding from year to year. To provide a little bit more, I think, context in that regard. I've outlined I've interviewed a number of the GME directors at the different medical schools and hospitals and come up with the number of steps required to create a GME program. And so programs have to hire recruit and hire a program director, which is a really big and important step. Then hire a program coordinator. And then once those two folks are primarily responsible for overseeing and managing the program at the institution, and then and developing the application for accreditation. They also have to recruit and hire faculty that will build build the program and build the application. And then once they do that, they'll develop and submit an accreditation application to ACGME. That committee will meet, and then there's an accreditation decision. And again, sometimes these take 6 months to a year in order to develop the program and get on the agenda. And then finally, the program will address any deficiencies if there are in their application. And then resident recruitment will begin, and regardless of when that program is approved by their ACGME accrediting body, resident recruitment begins in the fall, and then residents start July 1st. And so when you look at how long these timelines are, I think it can be very difficult to and inefficient for us at OSIT to have to deal with individual fiscal years, and then when for example, if we've budgeted a certain amount of funding for a particular program over a fiscal year, to have to then, if there's a delay in hiring a program director, that can push out some of the timelines beyond that fiscal year, and then we end up reverting some funds back to the general fund because they were, because simply the program just had some delays in ramping up their program, right? And then that means we have to pull money from a future fiscal year in order to meet our grant obligation or our funding obligation to that particular program. And so if we're able to dedicate a pot of money, and have that be able to balance forward over years beyond the fiscal year to that program, then that'll be more efficient for us in terms of making sure every dollar counts that's been appropriated to the GME program.
Thank you, Mr. Mitchell. I appreciate that very detailed walkthrough and hear what you're saying relative to the balance forward. I have one further question, though. If I am developing that program within the medical school, right? And we're investing in hiring a director and hiring a program manager and developing that. Is there a promise from OSIT, from this grant fund, that you're going to fund the development of that program? Or is that cash that I'm outlaying first to invest in the hopes that OSIT is going to walk alongside me later?
Thank you, Assemblywoman Brown-May, for the question, and I'm glad you asked, because that allows me to kind of clarify the process. So, when an institution, either a hospital or a medical school, applies for funding, what they're presenting to OSIT is an idea. They say, there's a need, for example, for pediatric emergency medicine, which is one of the applications we received a few years ago. Other than the cost of putting together a grant application, the applicant hasn't put together, or hasn't expended any funds. And so in their budget, the applicant would say, we need X amount of dollars to hire a program director, X amount of dollars for faculty. We might need some money to build out or renovate a space within, the hospital or within the medical school, and to buy necessary equipment. We'll need time to develop curriculum, so on and so forth. So none of those expenses have been, they're all planned and proposed to OSIT. And so then when we award the funding, then what we're awarding is a total amount of money, that includes everything that program would need from the very start to begin to recruit and hire that program director, all the way through the resident or fellowship salaries for the first cohort of residents. So we'll take them all the way through all the development, all of the expenses related to applying, doing the accreditation application, and then the expenses to ramp up and start up the program through that first cohort, however long that takes. So again, this is a multiple year endeavor, but the applicant wouldn't be out any money if they, either aren't funded or aren't, or aren't successful in their application.
Thank you for that clarification, Mr. Mitchell. I just have one other request. Would it be possible for you to share the rubric with us for the programs that you're currently assessing? How are you making those decisions based on your applicants? So if you don't mind, the rubric would be very important. And then can you just tell me how many other programs are you operating out of OSIT besides the GME?
Thank you, Assemblywoman, for the question. Brian Mitchell with the answer. Man, I'm struggling today. Brian Mitchell, for the record. The rubric is available publicly on our website. I'll make sure your staff gets a copy of it. We have posted the previous, the entire, whenever we solicit funds, we post the entire RFP on the website, and included in that is the rubric that's used. So everybody knows up front, how different programs will be assessed. Beyond GME, as I mentioned earlier, OSIT has two sides to the house. We are the state STEM office and the state broadband office. The state STEM office, we have a number of different programs related to teacher professional development. We operate the governor's designated STEM school program, and so we provide a STEM leadership academy, for schools so that they can become or learn what they need to do in order to meet the requirements for designation. And so we also have a number of other different grant programs related to providing more STEM equipment, like robotics equipment for schools, K-12 schools. On the broadband side, our mission is to ensure that every Nevadan, regardless of where they live, has access to a high-speed internet connection that's affordable and reliable. And so we're in the process of allocating funding to make sure that happens for everyone.
Thank you so much. I will come back to a broadband question. We're not done yet. So anyone else in Southern Nevada? Let's go to Northern Nevada. Dr. Titus.
Thank you, Mr. Chair, and thank you, Director Mitchell, for being here today and presenting. This is obviously a passion of mine, and I have several questions for you. Number one, on SB 350, as a co-sponsor of that bill, that part of that bill was to actually allow for the balanced funding to be brought forward and continue forward. Is that not your interpretation of that bill, sir? Do you? I'm curious. So balanced funding is currently in SB 350 that did pass.
Assemblywoman Titus, thank you for the question. Brian Mitchell, for the record. In talking with LCB fiscal staff, it was, as well as the staff at GFO, it was our interpretation that the funds are allowed to balance forward within the fiscal year. So all of the funding is appropriated at the beginning, all the funding for the biennium, rather than being divided between the two fiscal years, is appropriated at the beginning of the fiscal year. But then any leftover funding at the end of that biennium is reverted back. And I think I think the conversation we would like to have is allowing funds that are appropriated and then obligated during that biennium to balance forward beyond the biennium, so that there's a dedicated source of money over time, and if it takes a program 4, 5, 6 years to finish, that we have that funding available for them, and that we aren't essentially robbing from a future biennia to pay for a grantee that we award now.
So thank you for that. I think the intent certainly was to allow that to go forward, recognizing that it can take more than 5 years sometimes to start these programs. So thank you for that, and I think we'll have to look at LCB and readdress that if that's not clear to the staff, because it certainly was, I'm sure, Senator Pezzina's intent. You mentioned that you wanted it to stay in your department because your department is very nimble and that you can make choices and decisions. So I'm curious about how your department, you've been there, you said, for quite a number of years now. And in 2017, the University of Nevada started a rural residency program in Elko. And under your watch, in January of 2023, that program closed because the Northeastern Nevada Regional Hospital was not going to support it anymore. And I'm wondering, where were you in that, and was there funding available to step in and maybe save that program, recognizing that it takes years to develop these programs?
Thank you for the question, Assemblywoman Titus. Brian Mitchell for the record. The rural residency program at UNR in Elko was one of the residencies when we received the application and funded it. Was one of the ones that I was most excited about. Having been to Elko many times, I know that there's a great need for more doctors in rural areas. And as I've traveled the state in my capacity as the broadband director, there's a huge hunger for healthcare. That we're hoping. That telehealth and telemedicine can help address there. And so when the School of Medicine gave me a call and let me know that they were discontinuing the program, I was extremely disappointed that had happened. We were informed by the School of Medicine that it was a decision by the hospital, and that the School of Medicine was also very disappointed about having to close the program. I had several phone calls with the School of Medicine trying to figure out some alternatives to save the program, and ultimately the School of Medicine said that they were going to try to figure out some other ways to have some of their other programs that didn't currently have rural tracks to be able to go out and have rural experiences and be able to provide rural care. And that was the last we've left at it. The purpose of the GME funds, as has been approved by the legislature, was for startup expenses for new or expanded programs. And so it would not have been appropriate for OSA to allocate additional money to the hospital in Elko to continue the program. I think moving forward, I think there's we would hope to be able to re-engage with the hospital at a future date, and maybe when if their expenses or if their finances are a little improved, I know that the School of Medicine would be willing to restart that rural program because we know how important it would be to have it.
So there was no opportunity for you to say, hey, we could supplement some of that income that you needed from the funds? Is the language just so limiting in the GME funding that you didn't feel you could intervene?
Assemblywoman Titus, Brian Mitchell for the record. Ultimately, the purpose of the GME funds is to start, given the huge need that we have for new specialties and new programs and more doctors, we have always told the legislature that that's how we would use the funds. If we begin to become a line item in the budget, those funds would forever have to be allocated to that particular program, and we would never be able to create new programs because eventually we would just all of our the hospital would just say, without these funds we'll cancel the program, and so we'd have to continue. And so I think if there's a need for certain programs to have recurring revenue to sustain the programs, then I think that's a separate conversation that those program sponsors should have with the legislature, and that these GME funds ought to be reserved for the expansion of new programs in the state.
Mr. Chair, may I continue? I have a couple other questions.
Go ahead, Senator Titus.
So regarding SB 350, is the advisory council fully committed? Do all the members been appointed?
Assemblywoman Titus, I don't have the answer to that. I know that some members have been appointed. I don't know if all members have been appointed, but I'm happy to follow up with the boards and commissions staff at the governor's office and provide a response to you.
And the reason I ask that is that it's taken a long time for you to have somebody hire somebody, and you explained that to us. But I'm concerned that the moment that that person is hired, they need to be engaged, and so wanting to make sure that council is up and running. The next question regarding that is, you said there's a 6-month plan. Is that who wrote that plan? Is it something you created, and where can we find that 6-month plan?
Brian Mitchell for the record. Assemblywoman Titus, I put together an internal document to explain to the governor's office how once a dedicated GME staff person, a GME director is hired, how that person would then go about implementing SB 350 and the GME grant program. And so we are, working extremely diligently, and it's been a lot of work, and we're very hopeful that we're close. But at the same time, there's a lot of policies and procedures at the state level that govern how you go about hiring people that we have to follow.
All right, great. And final question. Thank you, Mr. Chair. So you talk about the moving or balance forwarding of the funds. How much funds currently do you have that you have not allocated and spent that you would want to balance forward?
Brian Mitchell for the record. Thank you for the question. Senator Titus. I apologize. I've been calling you Assemblywoman this whole time. Very embarrassing. Senator Titus, the amount of funding that we would balance forward, we won't know, because every quarter, we won't know until the end of the biennium, because every quarter, all of the GME programs will submit to us their quarterly fiscal and programmatic reports and their reimbursement requests. And so each quarter, we understand how much money they're spending, how their programs are progressing. We also talk to them about this during site visits and so on. And so the person who would be hired, and believe me, there's nobody in the state who wants this person to be hired more and faster than I do, would towards the end of the biennium, would work with the Administrative Services Division and the Governor's Finance Office at the state to then balance forward remaining funds, with no change in purpose.
I understand that you may not know what the future biennium is going to ask to carry forward. What about our last biennium? Do you know how much was left?
Given that we, Senator Titus, Brian Mitchell for the record, given that we didn't have this authority, we didn't go through the exercise of calculating a balance forward. But certainly we can take a look at past years and see if we can kind of come up with an estimate. I think it really kind of depends on the individual programs and how quickly they're able to stand their programs up. Again, some of the programs are more complex, may have different accreditation timelines, and so just depending on the mix of programs year to year, how much money may be left unspent, but obligated but unspent, may depend. So it's usually, though, given that it takes 4 to 6 years to build out these programs, it's in the millions of dollars every biennium.
Great, thank you. Because I know that there are programs that are just waiting to get started. I know Carson Tahoe is looking at doing a program, and I would hope that things become more efficient as SB 350 moves forward. So thank you for your time. Thank you, Mr. Chair, for the questions.
Thank you, Senator Titus. Assemblywoman Gray, do you have any questions?
Yes, Chair, I do. Thank you. Good morning, Mr. Mitchell. How are you?
Please proceed.
Mr. Mitchell, you there? There we go. So question, on your, by the numbers, it said 160 fellowships and residencies. Are those positions created or are those people that have already gone through?
Brian Mitchell, for the record, that would be the annual training capacity. So the number of slots or the number of people each year that are participating in a state-funded graduate medical education program. So some of them may be in a one-year fellowship, others in a four-year residency, but that's the number of people, the number of slots that have been created total.
Okay, and I know it's
in
on
other words, there's 160 people. In other words, there's 160 people total that are moving through the pipeline.
Got it. Okay, and yeah, and I know it's not a numbers for numbers comparison, but that's about $178,000 dollars per position to create those positions. So I'm wondering about the return on the investment for the taxpayers. Actually, are we tracking how many of those residents and folks are staying in Nevada? I mean, that's the crux, I think, is, how many of these people are we going to be able to retain, or have we retained so far?
Thanks for the question. Brian Mitchell, for the record. It's well known in graduate medical education circles that individuals or doctors are more likely to stay in practice where they do their residency or their fellowship, so their graduate medical education training, rather than where they do their medical school. And the numbers are quite, there's a huge difference. And so one of the risks that we have is if, the state is, if the state trains somebody at a medical school and then they go out of state to go do their residency program, we run a very large risk of losing that person unless they have a very strong tie to come back. It just doesn't happen. So when it comes to a return on investment, I think having more residency programs and attracting doctors that way to come to the state is a very large return on investment. That we would otherwise, I mean, if we were to substantially increase the number of medical students in the state without a residency home for them, we would essentially just be exporting a lot of doctors to other states. So this is a very important part of what we need to do to grow our physician workforce.
Thank you. I understand that there's a high propensity for them to stay, but out of the students that have been, say, put through under your tenure, how many have stayed in Nevada percentage-wise compared to how many went through? That's what I'm looking for. Are we actually tracking that and reporting it?
Brian Mitchell, for the record, on an individual student level, no, we're not tracking it. But as a state as a whole, those numbers are tracked and monitored by Dr. Packham at the UNR School of Medicine, and I'd be happy to ask him for some updated numbers and communicate those to the committee.
That would be fantastic if we could get that. I mean, especially by specialty. I mean, if we're turning out a whole bunch of general practitioners, we need neurosurgeons. Is the money going in the right spot? I want to make sure we are getting what we need in the state and able to retain it. So thank you, sir.
Yep, and for the record, Brian Mitchell, that's kind of the reason why we, do our homework beforehand and look at, the specific areas of the state and the specific locations in the state that are in need of greater fund or greater numbers of doctors. So we'll only award money to locations for specialties where for that particular specialty or subspecialty, the number of doctors per capita is below the national average.
Thank you so much. Assemblyman Gray, did you have one last question, or are we good to come back down south?
No, sir, you're good to go back south. Thank you.
Thank you so much. I'm going to reserve my comments. I'll let Senator Nguyen ask her last question before we go to me.
Thank you. I will try to be brief. I just have a couple of questions. I think a lot of people, just to clarify for the legislative record here during this interim committee, is I don't think a lot of people recognized in the public that OSIT not only, kind of manages like GME, but also K through 12 STEM education and broadband. So 3 arguably very different like areas of expertise. Are there things, I had asked initially about whether or not having GME, within this agency was the most appropriate thing. Are there things that we can do legislatively to empower and give more, I guess, expertise in this area, whether it's expanding like an advisory council or doing that? Can you think of anything that would make this more, I guess, efficient and more, I guess, professionalizing within this unique skill set? Does that make sense? How can we help you?
Brian Mitchell for the record. I think we have at OSET a very long history of excellent stewardship of the GME funds and of creating residency programs. And I'll scroll back up to that particular slide. We've awarded and created over 160 slots over the years, and so for us, I think at this point, we've really the most important thing for us, given we've kind of reached a tipping point where having another staff person, and this makes sense, right? As programs grow, you need to grow with administratively with them, right? And so, I think once we've hired this staff person, both to manage the workload as well as the additional responsibilities that were given to OSIT in SB 350, I think we'll be off to the races. So I can't think of anything right now, but certain that the legislature could do. But certainly, if open to continued conversation, and between now and the start of the legislative session, if either party thinks of anything.
And then just my other question has to do with this carryover or balance forward like money that you've been alluding to causing problems. Obviously, Senate Bill 350 is just from this last legislative session. And in reviewing it, I'll just concur with what Senator Titus had mentioned earlier. It's not a very large bill, and in Section 2, Part 5, it explicitly says that the legislative intent is that this money carry forward and balance forward. Obviously, some of those fiscal things that I put in some requests with fiscal staff to find out if that's just limited to grant funding and gifts, that they make sure that they don't revert back at the end of the biennium to the general fund, and that how that works. But if it hasn't been implemented, how do you know that this is a problem already? Is this like conversations that you're having in establishing these programs? Are we just too early into this process to know? Because I know that you have like a strategic plan that you're still actively working on. Is it just your anticipation that you will need these carryover funds like outside of the like normal budgetary process? Or I'm just curious on where that is as we're starting to, agencies are starting to formulate their budgets going into, the next legislative session already. So I'm curious on where that information is coming from.
Thank you, Senator Nguyen, for the question. Brian Mitchell for the record. I want to be clear up front that we've had a GME grant program in the state for many years. And so SB 350 didn't necessarily create anything new other than the advisory council. And if SB 350 hadn't passed, OSIT would have continued to award funds. The funding was, separate from, was appropriate, it was in the governor's budget. And so it was, so even in the absence of SB 350, it was always our plan to continue the GME program and move things forward. So there are a couple of tweaks, namely, having this council, but other than that, we still are moving forward. So when it comes to, this issue, of not being able to balance forward across biennia has been something that we've been dealing with since the beginning of the program, since 2016, so since our first awards. And so this is, it's not a theoretical thing. It's something that we've always dealt with. And in conversations with your fiscal staff, it was their belief that all funds that were left over from the end of a biennia. So again, to be perfectly clear, there is authority to balance forward unspent funds from fiscal year 1 to fiscal year 2, but not to balance funds left over in fiscal year 2 into the next biennia to continue to be able to use those with the same program. And so when in conversations with your staff, they told us that was their view, and we've complied with that.
Before we go to my questions, I'll let Mr. Robbins just make a quick clarification.
Yeah, Eric Robbins, LCB Legal. I've been looking at the budget bill that appropriated money for this program, and that bill is Senate Bill 511. And basically, Section 2 of that bill appropriates money to OSED, and then Section 40 of that bill says that of the money appropriated to OSED, there's going to be $8.53 million appropriated to support grants to establish new GME programs and is available for 2023-24 and 2024-25, and that they're available for both fiscal years, but then that money would revert at the end of the biennium. So the bill, the language of this is kind of the language of the bill that so that people can look it up and see what you're talking about.
Thank you so much, Mr. Robbins. I'm going to ask a separate question since I have you, and it's not a curveball. I want to continue talking about healthcare access, and I remember that you're also facilitating broadband access statewide. So I'm going to ask you a question not related to Senate Bill 350, just because I have you here, and then most of my comments I'll reserve until the end of the question. So in terms of broadband access, I know that when we talk about expanding access to healthcare, telemedicine, a lot of that in the rural areas is vitally important, because oftentimes some facilities might not have the capacity, and the numbers might not make sense to open a full facility in some parts of the state just because of the magnitude of how big we are. But broadband can help us achieve a lot of the goals that we have for access to care. So what are some of the initiatives that we can do to support you in terms of broadband access? And have there been any discussions of what we can do to empower physicians or medical professionals to ensure that they have the capacity to do telemedicine in parts of rural Nevada that they might not be able to?
Thank you, Senator Doñate, for the question. Brian Mitchell for the record, and not a curveball at all. It's a fastball right down the middle. So I think, when it comes to broadband, there are so many different applications for broadband that that can benefit society generally, and access to healthcare is certainly at the top of the list. And I think as a first step in anywhere in the state, whether it's rural Nevada or even here in Las Vegas, where folks have medical needs but they don't have reliable transportation to get to a doctor's office. It's so important that we figure out how telehealth and telemedicine can play a role in increasing access to care. So I think as a first step there, we need to make sure that people actually have access to broadband in their home. So that's having an affordable connection, having a reliable internet connected device, and then having the digital literacy or the digital skills needed to feel comfortable using that device. And as I've traveled throughout the state, particularly in rural areas, a lot of folks just simply say aren't comfortable conducting medical visits via telehealth or virtually. And so there's some amount of education and some amount of instruction that we'll need to do as a state in order to get folks, particularly in areas where, where they don't have ready access to healthcare, to feel more comfortable with that. On the other side of the equation, the medical professionals and the healthcare community will need to, figure out, there's a lot of different things, that, related to, telehealth parity. And so I know there's folks in the room who are a lot more, knowledgeable about things like reimbursement rates, for telehealth visits, or making sure that doctors are properly trained in how to conduct healthcare visits, or having the right equipment, both at the rural healthcare site and that can link up back to a specialist in a place like Renown or UMC. And so there's a number of different kind of pieces there, and I know that there's a lot of folks that are kind of trying to solve for things on the on the healthcare practitioner side, to set ourselves up well. And where I see OSIT's role on that is more, getting people the infrastructure to their house so that they can connect, or the infrastructure to their health clinic in their rural location, and then helping folks to be able to feel more comfortable or more digitally literate so that they're more willing to participate in telehealth.
No, I mean, I appreciate those comments and sentiments, because I think you are right. I mean, we do have to there's more that we can do to help empower individuals, especially those that live in the rural areas, to make sure that they have access to care. And like I mentioned earlier, that broadband is the connectivity that can help us reach those communities. And that's kind of why we had there's a telehealth bill that came last session in terms of parity and continuing the extensions that we had during COVID-19. And so I know there's obviously room to grow and make sure that we're reaching our milestones so that every home in Nevada is equipped and connected to the internet should they need it. And then just to close this conversation out regarding SB 350 and GME education. The reason why I wanted to bring this request for presentation was because I think that in general, what we've seen with GME, and we have our deans ready to present right after this, is that GME is complex, and it's not an easy issue to just solve just by the nature of throwing dollars to it, right? I think the dollars can definitely get us one step closer, but we're fighting against a system that has predated a lot of the infrastructure that we have in this state itself. A lot of it is predetermined federally, and so I think it's important for the public to understand that there are things that are out of our control. And then, of course, we need to make sure that we do our own level of investments and make sure that we're following and setting up an infrastructure of our own. And I think that's kind of the reason why I pulled this presentation together. In my personal perspective, when it comes to GME education, there are several issues that come to play. Oftentimes I think there's a rhetoric that residents are treated as free labor, and just speaking with some of the residents and students that I know, and that certainly is not the case. I think that there's many of us that would love a system where the residents can stay in this state once they complete their program. I know that if I remember correctly, about 39% of the students that complete their residency program end up staying in this state. There's obviously a large portion of them that are leaving post-residency completion. And so I think that's why we have conversations of childcare, education, housing, reimbursements, all of it come to fruition, and it's not just one piece of the puzzle, right? And so part of my goal, and I would hope that through this presentation, that at least the committee members have some level of understanding of where we need to go, is we need a strategic plan, right? It's not enough to just say we're going to open this grant program and facilitate applications for GME and then see and each of them how those programs are coming to fruition. We need a strategic plan to say these are the initiatives of where we're following the most in gaps of care, and this is how we're going to accomplish it within the next 5 to 10 years. So by the time we get to 2030, we already know what the residencies that we need to invest in. Because ultimately, if you ask a healthcare provider, if I work in primary care, I'm going to tell you the one that is most important is the residency programs in primary care. If you work for a cancer research center, the ones that they're most important for them are cancer research fellowships, right? All of this needs to be coming together, and I think over time, what I think have understood just from this presentation item is you don't have the support systems that you adequately need. And perhaps we need to focus and revamp what the office mission is, and perhaps we need to look at creating either a bureau or some type of administrative level position that actually has the support staff that you need, not just the director that you were allocated to, but we need an actual strategy of healthcare workforce and how the students that are going through the K through 12 system and learning about STEM can actually become healthcare practitioners. That's what the mission, I think that's what's missing in our state infrastructure. And so I would hope that when we discuss GME, which we'll go through all throughout today, when we talk about access to care, I would hope that that's something that we can accomplish in 2025. And that was the reason why we brought you to today. But I know the governor has mentioned that this is his priority, and you alluded to that in the beginning. I know it's a part of his strategic plan, and so I think it's up to all of us to ensure that we're delivering on that. And so I think that there's obviously room to grow, and I know that you have things that you have to follow up on with us, but just know that we can be partners with you and that we can help ensure that the programs and the monies that were allocated that are actually coming to fruition to expand access to care. And so all that to say, we greatly appreciate your presentation, and if there's any other follow-up comments, I'm sure we'll do it offline. So thank you so much.
Well, thank you, Senator, so much for having me, and consider my office a partner with you as well in ensuring that we have the physician workforce that we need in the state. I appreciate the time to be here.
Thank you so much, Director Mitchell. We'll go ahead and move out of order. I want to go into the next presentation of our presentation from Nevada Schools of Medicine. I know that we just had a robust discussion on GME, and I know our deans are excited to be back, and so we'll go ahead and welcome them to the desk, and then we'll get started. For this presentation, we do have Dean Hauptman, who is a dean from the University of Nevada Reno School of Medicine and the Chief Academic Officer for Renown Health. And we're also joined by Dean Kahn, who is a dean for the Kirk Kerkorian School of Medicine and the Vice President for Health Affairs at UNLV. So please begin when you are ready.
Mr. Chair, Vice Chair Committee, thanks for allowing us to speak. My name is Mark Kahn, and as mentioned, I'm the Dean of the Kirk Kerkorian School of Medicine and Vice President for Health Affairs at the University of Nevada, Las Vegas, and my colleague.
Thank you, Paul Hauptman. I am the Dean at the University of Nevada Reno School of Medicine and Chief Academic Officer at Renown Health. We really appreciate the opportunity to present an update for you, and I think we'll just begin with some numbers and then we'll drill down further. In terms of the two public medical schools in the state, we educate approximately 550 students. The average annual number of graduates is 122 and growing. We have multiple GME programs as well, and Dr. Kahn will address that.
Yeah, so collectively, we have 471 residents and fellows between the two public medical schools. I estimate that we have about 90% of the GME positions in the state between us, but we can work on getting you some exact numbers. Annually, we graduate about 148 residents and fellows collectively between us. And allow me this opportunity to thank Senator Pezzina and the co-sponsors of the Bill 350 for working to expand GME and fund GME in the state. And I'd like to, again, thank the committee for offering Dr. Hauptman and I the opportunity to address questions.
We also have a PA Studies program at the University of Nevada Reno School of Medicine, 48 students. It's a 26-month program. The average annual number of graduates is 23. That also helps to improve the healthcare workforce.
So there are benefits to public medical education, and Dr. Hauptman and I, over the past year and a half or so since he's been here, have been really working closely to expand medical education in the state to address access to care and to address really some critical needs for health care in our state. We're working together to expand graduate medical education. We appreciate this committee and the opportunity to talk. And we would argue that as the deans of the state medical schools, we know what is necessary to create and build GME programs. Collectively, both of us have probably about 60 years in that arena to date us a little bit. And we also, I think, are in a position to understand the needs of the state. And for GME, it's not just locating a program in the appropriate place, it's also having the available faculty to develop curricula and to train the next generation of physicians.
And you've heard during the prior presentation a number of data points about retention. I just want to go over in broad brushstrokes the retention numbers. These come from John Packham at UNR Med. It's what I call the 40-60-80 rule. So 40% of our medical students will ultimately practice in the state. 60% of our graduating residents will ultimately practice in the state. But if you combine attendance at a public medical school in the state plus a residency in the state, the retention rate goes to 80%. It's hard to do much better than that. I should also point out, not only do we have a PA studies program, but at UNLV there's a School of Dental Medicine, at UNR Med a speech pathology and audiology program, and we're looking to grow those graduate programs as well.
So I think I speak for my colleague, Dr. Hauptman, when I say really the public medical schools, funded in large part through taxpayer dollars, are here to improve access to care by training the next generation of medical personnel.
And so we do talk a lot about the physician supply, especially in rural settings, and we do believe that there is an opportunity to grow rural tracts and rural residencies, plus expanded loan repayment programs, which at this point attract approximately 50 physicians as they pay back their loans and serve in rural communities. That program is also run out of UNR Med.
So as a relative newcomer to this state that I call home and have grown to love, what impresses me is the fragmentation of healthcare. So at UNLV and now at UNR, we're trying to further the concept of academic health. So there are about 130 or so designated, recognized academic health centers in the United States. Dr. Hauptman and I would like to create academic health in the North and South. So under one umbrella, with him leading the charge in the North and us leading it in the South. So when I look at UNLV, we have 5 health science schools. We have a School of Medicine, we have a School of Dental Medicine, we have a School of Nursing, we have Public Health, and we have Integrated Medicine. And then we have behavioral health that's distributed across 3 or 4 colleges. So we've been working together for the past 3 years or so. We've developed a strategic plan. We're in the process of updating it for really bringing this coordinated care to our community, where patients can come and almost in a one-stop shop get the care that they need. Let me give you an example. I'm an oncologist by training, and what typically happens here is a woman discovers a breast lump. She finds her way to her primary care provider. She's subsequently sent for a biopsy. She's then sent to a surgeon. She's then sent to a medical oncologist, and finally maybe to a radiation oncologist and maybe a mental health professional. This really needs to occur all in one place, all at the same time. And that's one of the things that academic health can bring to this community. At UNLV, we're working very closely with our partner, UMC. And at UNR, they're working very closely with their partner in Renown. And several weeks ago, the CEO, Mr. Van Halling, and I went up to UNR to meet with Dr. Hauptman and the CEO at Renown to see what we can better coordinate together and to see what we can learn from each other.
Thank you. So I'd like to just point out in terms of GME, before we move on to other issues, that we take as our model the state of Texas, which sets aside $200 million in each biennium for new programs as well as to sustain existing programs. Given that we're about 1/10 the size of that state, we believe that a $20 million figure per biennium is reasonable, and we would like to propose that the 2 public medical schools be awarded as part of their regular state budget, $5 million a year to grow GME. We are committed at UNR-Med, and I believe Dr. Khan likewise at UNLV, to grow 5 new programs by 2030. And in order to do that, we need the financial backing of the state. In addition, philanthropy, and then the hospitals will contribute as well. So I think we've addressed the, if you go to the next slide, please.
Oh, we're going backwards somehow.
Next slide.
There we go. I'm sorry. Yeah.
So we've talked about graduate medical education and academic health. I'd like to also point out that Dr. Khan and I are working together on a project which we believe would be of great interest to the state, and that is to stand up a Nevada Center for Patient Safety and Simulation. And one of the major advantages of such a center would be for our ability to take medical simulation to the rural hospitals, which is a real gap. The cost of mannequins is tremendous. They often cost over $100,000 each, and then you need individuals who are steeped in the education of simulation in medical settings. And we have those skill sets, and we'd like to stand up this center for that purpose. There are a number of additional programs. I'd like Dr. Khan to touch base on those.
So one of them is that both UNR and UNLV, we want to make sure that we ensure student success. So both of our schools have been successful with graduating physicians, with having physicians who match, with having physicians who pass their standardized tests, but there is a need for support, learning specialists, career advisors, et cetera, and we think that's critical for getting the workforce that we need.
In addition, as I mentioned, we are looking to expand a number of our graduate programs, and specifically master's degree programming in speech pathology, which clearly needs to grow. It is an unmet need in the state. We would like to stand up a new program in medical laboratory science. If you reach out mostly to the rural hospitals, there's a dire need for individuals to direct a hematology lab, a chemistry lab, a pathology lab, microbiology lab, and that requires special education, and we believe we have the ability to stand up such a program. In addition, we're looking to begin a clinical trials administration program that would be a master's degree.
And at UNLV, we're very thankful that in the last biennium, through the governor and the works of the legislature, we received some monies to increase our class size. We just want to remind this group that that was intended to be recurring because we can't hire faculty for 2 years. We're not going to get permission to increase our class size. So really, we have a huge priority to make sure that that is a recurring item in our budget. We started out with 60 students a class. We're allowed to increase by 10% without specific permission from the accreditors. This past year and this upcoming year, we're going to have 66 students, but we'd really like to get to that 90 number. We're in the process of hiring faculty, so we'll be able to do that, but those dollars really need to be recurring.
I'll also point out that at UNR-Med for the first time this year, we are prospectively recruiting students into an MD, PhD program.
Great. It's great.
So we were asked not only to talk about fiscal priorities, but policy priorities. So I think the first one is you recognize it's sustained and reliable funding for GME at the 2 public medical schools and affiliated partners.
And importantly, we're asking that this group and others consider that the funding go to the state medical schools. Again, we're in a position to be able to develop curricula. We don't have a problem finding program directors, and I think we're both together in a position to see what's best for the state. We'd also, I see that there are members of the Board of Medical Examiners here, but both of us feel that we really need a streamlined licensing process. Without getting into details, both of us had a rather substantial delay in getting our state licenses in spite of our training and records to date. And similarly, I think we need to work on speeding up the process to get our providers in state credentialed with state agencies like Medicaid. And finally, we last budget we thank our elected officials, Senator Lang, for helping us get a bill that allowed faculty at the state medical schools to have access to insurance panels. We really need to strengthen that bill. We're not getting traction, and we're still being blocked from entering panels. What that means is that we then lack the ability to have trained providers to train the next generation of physicians.
And I'll just conclude by saying in the photograph in the upper left, you'll see 4 of our medical students who in the last biennium traveled to Carson City with us to testify. They are the best diplomats and supporters of medical education in this state, and they feel passionately about the need to grow GME. So with that, we thank you for your time and are open to any questions you may have.
Thank you so much. I'm going to start with my questions first, but it's mostly for your slide. Can you go back to the fiscal priorities?
You're asking me if I know how to reverse this.
Or, I mean, maybe you know it from the top of your head.
Maybe there's a...
Just a backspace.
There we go.
There you go.
There we go. Got
Okay. Can we go through just the line items of how much you're looking for each of these programs?
Sure.
That would be helpful for us.
So for GME, I think that we talked about, again, the state of Texas provides, as my colleague said, $200 million for GME. In their biennium, we're about a tenth of the size, so we're asking for $20 million in the biennium.
And I'll just make a point that program has been incredibly successful. It's not just picking out a number and saying that's what we want to recreate in Nevada. They have made it as their goal that the number of slots in GME, new slots in GME, exceeds the number of graduating students from all the medical schools in the state, and they've achieved that. So that is to say there's 1.1 internship slot available for every 1.0 medical student that's graduating.
For academic health, we've talked a little bit. We actually did get a little bit of funding last year for academic health. So I think we're talking about $2 million between the two schools, probably $1.5 million for UNR and $500,000 for UNLV. That'll get us the same number over the time period.
With regard to the Nevada Center for Patient Safety and Simulation, we're looking for seed funding on the order of $2 million, $2.1 million over the biennium. We believe that we will qualify for some additional potentially federal funding, and it's a great philanthropic cause, too, from our perspective.
For increased support for student success, I think that we're talking about $500,000 probably.
And then for the master's degree program, each one of them has a separate line item budget, and be happy to share that with the committee.
And for increased class size, it was $9.2 million in the biennium that we'd like to see recurring. Thanks.
Great. Thank you so much. All right. Now we'll go to questions from the committee members. Assemblyman Nguyen.
Thank you, Mr. Chair. I wanted to go back to the graduate medical education number that you said, comparing us to Texas. As much as I want us to compare it to them, I just wanted to, and I think I have had this conversation with you before, is that rather than just say compare to a similar state, let's just look at the program as a whole, right? We are behind. We all know that, and we can say that every time we talk about anything HHS related. So $20 million is a good percentage in terms of if we compare it to Texas. How about we just compare it to the needs that we have, and the needs are, I know it's a little bit more dire. So let's just say if the number is, we're in a perfect world. What does that number looks like for us to kind of be up to par so we can have an idea? Because I think if we want to, I guess, look at things in the long run, and how can we look at not just this biennium, but just look at 10 years down the road? Because as I think Dean Hoffman, I talked to you last, is that it takes 4 years to get a program up and running, right? So by the time we get these funding, we're going to come back and ask for different kind of a resource. So I just want to get both of the experts here and give us an idea of what that number, the actual number really looks like if we just look at Nevada by itself and not compare us to another state.
Thank you, Assemblyman Nguyen, and for the record, Paul Hauptman from UNR Med. Let me try to answer it this way. At this point, we are projecting that we could stand up 5 programs by 2030, an OBGYN residency, a rural track and family medicine, a fellowship in addiction medicine, a fellowship in cardiovascular medicine, and a residency in surgery. That will keep us quite busy between now and 2030. We have a green light to move forward, at least administratively, with an OBGYN residency, and we are projecting a start in 2026. That timeline is short. That's a 2.5-year timeline for us to get a curriculum, get initial accreditation, and do our recruiting. But we believe that that's feasible, and then the other programs would be added on from there. The actual dollar amount really depends on which program and how large they are. So as an example, the minimum number of residents in a general surgery program that's allowable for accreditation purposes is 5. That means at full maturity, the program will have 25 residents. So that program will be very, very expensive compared to a 1-year addiction medicine fellowship, where you have 2 fellows a year, and it doesn't grow year over year. There's just every year you can count on there being 1 to 2 fellows. So it's a little bit hard to come up with a strict figure, but of course, if the legislature is favorably inclined to more than $20 million over the biennium, we would be very supportive of that.
Yeah. Mark Kahn, for the record, for UNLV, the programs that we're entertaining include, in no particular order, anesthesiology, dermatology, ophthalmology, anesthesiology, and hematology, medical oncology.
And thank you for that. So I guess what I'm looking for is that if we could be more descriptive, hopefully, and you don't have to have the answer now. I mean, you can come back, and I know I'm meeting with you both later on next month. In terms of just give us like that perfect picture, right? For $20 million, you're going to get 5 more programs by 2030.
We're actually going to get 10.
Or 10, okay? For $40 million, you're going to get, 20. I don't know if the more program, the less of a discount we get. I don't think it works that way, but if there is a roadmap for us to see, right, in the perfect world, if we can truly cover all of the specialties here in Nevada, what would be that price tag, right? And it has to be broken down by, a 10-year strategy or a 20-year strategy, just so that if we look at multiple strategies, we can figure out what would be the best and somehow look at it from a much more urgency perspective, if you will. So yeah, if you don't have that number now, it's fine. We can continue to look at this number more, but I want to see how it looks like if we have a long-term roadmap, and that would be helpful in terms of how we can see if we can create more resources.
Thank you for the question, Assemblyman Paul Houtman. For the record, I would say it this way, if we did a back-of-the-envelope calculation, the OBGYN program, which is an intermediate-sized program, it's not as small as addiction medicine, it's not as large as general surgery. At full maturity, our projection is it would cost about $2.7 million a year to maintain. That's resident salaries, program directors, and all the other ancillary requirements for keeping a program fully accredited and thriving. So if you multiply that figure by 5, that gives you some idea what that would look like for our goal of reaching 5 by 2030. I will point out, however, that I don't think the onus needs to fall entirely on the state. I mean, we are pursuing philanthropic dollars, and the hospitals themselves have a benefit by bringing these programs forward. It's a pipeline for them, and it also, you have individuals who can work up to 80 hours a week, if need be, to provide direct patient care. So I think this is going to take a village. It's going to take multiple sources of support, and that's what Dr. Khan and I work diligently to obtain.
Dean Houtman, just really quick, I know I have my set of questions at the end, but I just have a quick clarification. Have you had any conversations with any of your colleagues from other states, and this can go for Dean Khanna as well, I know that other states have implemented Section 1115 waivers to try to look at GME payments and the FMAT, the federal matching funds for GME. Is that a conversation you've had with other colleagues? Is this relevant to this conversation, or?
Thank you for the question, Senator Donyate. Paul Houtman for the record. Could you just clarify which federal mandate you're referring to?
Sure. So in some states, they have utilized Section 1115 waivers through Medicaid to, I mean, they're essentially to create different initiatives to help fund GME payments. And so they've used managed care as an opportunity to help expand like the payment delivery for GME slots, et cetera. So have you had that conversation with other states? Or, I mean, I guess, and the reason why I'm asking this question is because, as you mentioned, there are other states that use other pools of money, perhaps some fees or T word associated with it. And so I guess the question is, what other mechanisms have you seen in other states implemented to help provide that recurrent funding?
Right. Thank you for the question, Paul Houtman for the record. The timing of the question is impeccable because next week Dr. Khan and I will be at a Council of Deans meeting in New Mexico where all the medical school deans from the United States will congregate, and we'll certainly have an opportunity to discuss this with them. We are in Reno looking, along with our hospital partner, at Medicaid Uplift as an opportunity to help GME going forward.
And Mark Kahn, for the record, Senator Donyate, I think you're hinting at an all-payer system. So GME for the past multiple decades has really fallen on the shoulders of the Centers for Medicare and Medicaid Services, the federal government. As was mentioned earlier, those funds were frozen by a Balanced Budget Act that passed in 1996 and went into effect in 1997. And we were a very different state then than we are now. I don't think Dr. Houtman and I, either of us, are very optimistic that we're going to get substantial federal funding to help. And I really think it has to come from the states. It's got to come from the hospitals. Both of us are looking at philanthropic sources to start GME, and it really has to be all in if we're going to catch up to where we need to be as a state.
That's great. Thank you. And the reason why I'm asking these questions is because I think I would implore you to work with our Medicaid folks statewide to develop these ideas and these initiatives. I know there are several states that have looked at this issue, and so I think there's a collaboration that could exist potentially as a bill to help mobilize and start this conversation in the near term. I'll stop for now. Do we have any other questions in Southern Nevada? Let's go to Northern Nevada. Senator Titus.
Thank you, Mr. Chair, and thank you, Deans, for being here today. It's a conversation that is very important throughout our state, and especially to me. I have a couple questions. First, a comment that my bill that I brought through last year would have solved this problem with some of this funding had it gone forward, so we may be having to revisit that. The questions I actually have, though, are, so you're two of the public schools here in the state of Nevada, but we have private schools also. And I'm wondering what collaborative efforts that you are doing with the private schools that are trying to set up these residency programs also.
Mark Kahn, for the record. Thank you, Senator. So there's one private osteopathic school, that's Toro. The dean and I have lunch at least once a month and probably talk every other week. They do not have residency programs, nor do they have plans to start residency programs, at least through my discussions with Dean Gilliar. The other medical school is not yet accredited. That would be Roseman. And again, Drs. Gilliar, Greer from Roseman, and I have lunch every couple months as well. And it's my understanding that they don't plan to start residency programs either. So when you look at medical schools, it's really the two public medical schools that are predominantly in the residency and fellowship business.
Thank you for that, because one of the things they're going to be producing DOs, MDs, and so they're going to want to have these slots, these graduate medical education slots also. Along that same line of questioning, how involved were either of you in trying to save the residency program that we did have in Elko that closed in January 2023?
Thank you for the question, Senator Paul Houtman. For the record, we were obviously very involved in that decision. It was our program. And I echo the sentiment of Director Mitchell that we were very disappointed that the hospital decided to withdraw funding from the program, which left us in an untenable position of continuing the program. We are in active discussions with 2 other rural hospitals that are a bit closer to Reno at this juncture in an effort to stand up a new program there. One thing that we're discussing is potentially combining the rural track with an MPH with a concentration in rural medicine. So I think there is some optimism there, but I do not see a future at this juncture for standing up the program again in Elko.
So thank you for that. That it's very unfortunate. So how are you reaching out to the other hospitals in the area? Because clearly that was a non-supportive regional hospital. So are you garnishing support in these other regional hospitals so that this doesn't happen again?
Thank you for the question, Senator Paul Houtman. For the record, we are in discussions with 2 hospitals. There's one that is in the lead, if you will, in terms of their level of interest, and we have hired a consultant from the American Academy of Family Physicians to help us do a critical analysis of their readiness to stand up a program for precisely the reasons that you're outlining.
Again,
Mark Kahn for the record.
No, go ahead.
Yeah, Mark Kahn for the record. And Senator Titus, we do have a rural residency program in the state in Winnemucca. It's small, but it exists, and I, again, applaud my colleagues' efforts to try to expand. I think that's something our state needs.
So are you? So I'm aware of the application for Carson Tahoe. They're interested in starting something. Is that one of the programs you guys are referring to?
Senator, thanks for the question. That is not one of the programs we're referring to. That would be a separate standalone program. It's my understanding that Carson Tahoe, this is their first step into GME, that they do not currently have programs.
Right, and I just want to make sure that throughout the state that there's not any territorial concerns that you as deans are welcoming to other ideas for expanding GME in our state, and so I'm bringing this up to make sure that what happened in Elko doesn't happen again. If we have other areas, other schools, or other hospitals with some of their own ideas, and hoping that that communication stays, so that it's kind of, in my mind, all hands on deck to make sure our state expands these opportunities. More of a statement than a comment.
Thanks. Understood. Thank you, Paul Houtman. For the record, I would just say that GME is increasingly a complex exercise, partly because of ever-changing accreditation environment and because of the rapid changes in medical education. And we believe that our combined experience and the experience in our institutions make us leading candidates, if you will, for the growth of GME in the state. That's not to say we would block anybody else from stepping forward. We would just want them to be held to the very high standard that we've set for ourselves.
I appreciate that, and thank you, and we'll be watching. Thank you very much.
Thank you, Senator Titus. Assemblyman Gray, do you have any questions?
No, Chair. Thank you.
Thank you. Dr. O?
Yeah, thank you. Just a couple quick data questions. The comparison with Texas is very helpful. Thank you for pointing that out, Deans. You mentioned that they have 1.1 residency slots for their graduates. Where are we currently? Are we half that? Where are we?
We have, for the record, Mark Kahn, we have 404 or so, 404 CMS-funded slots for the entire state. When you compare that to California, that is over 9,000, and New York, that has some 17,000, we're the number of spots we have is really woefully inadequate. You can add to that some VA positions, some hospital positions. We probably have, certainly our ratio of graduates to GME spots is less than 1. It's less than one.
I would just.
Okay, so it sounds like, thank you. It sounds like you're also saying that because we have so few slots, we need to rely on recruiting physicians from outside, that if we just kept all of our medical students, that might not be enough?
Mark Hahn for the record. Yeah, so, I think, so we showed you numbers from the two state public schools. The osteopathic school graduates 181 students a year. So now you see how high our numbers are. So we probably have approximately 0.75 residency positions per graduate. So our residents, our graduates, our students have to go out of state. And as we've mentioned, there are specialties that aren't even represented in our state, like dermatology, like urology, like ophthalmology. So, we have a lot of work to do, Senator.
Right, and Paul Houtman for the record, I would agree with Dr. Khan on that point. It's not just that the residency slots are available; it's the waterfront of what are students looking to pursue in terms of their medical careers at this point. And some do want to go into family medicine. There's no question about it. But the specialties are still in high demand, and frankly, it meets the demand of our patients as well. If you want to get a visit with a radiologist with a rheumatologist in this state, it's probably going to be a wait time of 6 months. That's just simply unacceptable.
Thank you.
Thank you, Dr. O. Let's go back to Southern Nevada. Do I have anyone down here? Assemblywoman Brownlee.
Thank you. Thank you for your presentation. I just have a clarifying question. You talked about 404 state GME slots and the numbers of slots that we're currently utilizing. Is that specific to the state schools? Does that include Touro University or other private nonprofit schools? How does that affect the number?
Mark Hahn for the record. Thank you, Assemblywoman. So residency positions are sponsored by either a hospital or a medical school, but students from other programs come into those programs. So we will find out, Dr. Houtman and I, on Friday at 9 o'clock where our students are going. Similarly, the students at Touro, and again, they don't have their own residency programs per se, but they will find out where they're going to go. And many of their students are going to go to each of our programs. So these aren't exclusive at that level. So the 404 are the numbers of Centers for Medicare and Medicaid Services sponsored spots allotted our state.
Senator Nguyen.
Thank you, and I'm going to apologize in advance for my rambling, and hopefully you can follow with me. Of those 404 residency spots within our state, how many of them are how many of those programs are housed within, I guess, what would be the closest to public institutions?
Dr. Houtman and I estimate, and we can get some exact numbers, that about 90% of the residents are at one of our two, affiliated with one of our two schools. Remember that even those are the funded spots, but I know Mr. Van Halling's in the audience, and he would jump to say that his hospital actually has more residents than they're funded for. And unfortunately, that's true for about 70% of academic health centers. So I'll get the numbers close, but not exact. But you might be funded for 205 positions, but his hospital actually has 254 residents. So there are residents that are overcapped or are unfunded. But in answer to your question directly, we estimate somewhere around 85 to 90% of the state's residency programs are affiliated with one of the state medical schools.
I guess the reason I ask is obviously we live in a state where we can't overlook the fact that the majority of the hospitals that are operating in this state are private hospitals. And so when you're talking about, and it kind of goes in direct relationship to our previous conversation with OSET, do other states have a more coordinated effort to like facilitate not only graduate medical education, but workforce development, like that is specific to this healthcare space and these intersecting private, public, federal, I guess, dollars into coordinating a more, I guess, efficient use of those limited spaces federally, as well as where you're inserting dollars? Like, would you be open to a more statewide residency program funding model? Or is this a territorial thing where everyone wants the money to go directly to them? Does that make sense?
Yes, thanks for the question and the comments, Paul Houtman, for the record. I would answer this in a number of ways. Again, quality control is extremely important. We're confident in our curricula. We're confident in the quality of the individuals on our faculty who do the teaching. We do collaborate at UNR Med, for example, with the VA, and a lot of our residents spend time at the Sierra Nevada VA health system, and we're confident that they're getting a top-notch education there as well. But to expand a particular residency slot to multiple locations across the state is probably problematic too. The residents themselves are not going to want to get in their car and travel all over the state and move their families for 3 or 6 months at a time to do rotations. I will say that it's our position that when you're dealing with tax dollars, that the public medical schools really should be the primary beneficiary. The largest purveyor of graduate medical education in the country is a for-profit hospital chain, HCA, and they're doing that out of for business reasons more than anything else. We're here to educate the next generation of doctors to take care of Nevadans, and that's our primary goal, and that would be the goal of our hospital partners as well.
May I follow up, Chair? Are there things that other states do to like have those protections? I mean, obviously, when you have like private hospitals operating a majority of those programs, they might be inclined to do ones that are more profitable. I don't want a bunch of like ortho doctors, like residency programs or like things that I guess are needed as well, but also wouldn't diversify the type of education programming. Are there like protections that other states put into place to make sure that we don't just get one type of residency program in private hospitals?
I think it's on Mark Kahn, for the record. Thank you, Senator. I think other states, other states that fund GME, and that's not every state, but other states that fund GME, I don't believe that they send many dollars to the for-profit entities. So we're a little bit different that way. I think that to get to your point, who's looking out to make sure that the state is getting the types of residents it needs? I think, that gets to the question that Mr. Mitchell discussed and that the committee that Dr. Houtman and I sit on will address. But I think that you're right. That absolutely needs to be coordinated statewide. It would not make sense, for example, for Dr. Houtman and I to both want a radiation oncology program. There just isn't that great a need. That should live in one place or another. And right now, he has a cancer center. So, it's those types of decisions that would help to drive. But suffice it to say, the state does not have a single radiation oncology training program, and it needs one, right? So I think that would be the role of an oversight committee. And again, I think the public entities are in a position to look out for what's best for the state.
Paul Houtman, I might also just add that we have the opposite of an embarrassment of riches in the state. Depending on which discipline you're looking at, we rank 45th to 49th in terms of doctors per capita. So you could almost argue that any training program can be supported and justified on that basis.
And then I can follow up offline, but you had mentioned people not wanting to like travel around. Other states, I believe, have like rural GME programs. Is that something that would also be considered, or?
Yes, thank you for the question, Paul Houtman, for the record. We again would like to start a new rural track in family medicine, and in that it's called a 1+2 program. They'll spend 1 year in Reno, and then they'll spend 2 years at the rural site and move themselves and their their families there. I think what I'm referring to, there are instances where trainees have to travel to different hospitals. In fact, now in OBGYN programs in states where abortion is illegal, those residents are finding the need to travel to different states in order to get training.
So sorry to put you on the spot. So you're not necessarily opposed to having a more comprehensive statewide funding, I guess, program or formula that would benefit all, I guess, residency training and workforce development and all of the above?
Paul Hauptman, for the record, I think what I was addressing was in any given program, because of accreditation requirements, you really need to have a sponsoring institution and be responsible for the education in that sponsoring institution. If you're thinking about an OBGYN residency, for example, that is statewide, that won't be viable in the eyes of the accreditation body, the ACGME.
Okay. Thank you.
Let's go to Senator Titus.
Thank you, Mr. Chair, and I appreciate an opportunity to ask another question. I'm just curious, we haven't had much of a discussion. We're talking about GME, and just so for clarity, fellowships are also part of that discussion. Is that not correct? And that hasn't been really mentioned.
Mark Kahn, for the record. Thank you, Senator. Yes, fellowships are certainly part of GME. Both my colleague and I have done fellowships, so we know about those. And as you know, as a physician, sometimes these are all lumped together as residencies, even though they're fellowships. So even in the common vernacular, they're sometimes combined. But yes, we're talking about both. We need expansion of fellowships as well as the primary programs.
Right, because somebody mentioned earlier they couldn't get to see a dermatologist, get to see a rheumatologist or neurologist. And just to be clear, you could start your internal medicine residency, but boy, those are all then subsequent training and subsequent fellowships and cardiology, et cetera. So I appreciate that. When you give us the numbers about breakdown, it would be nice to see what the anticipated numbers of fellowships you're looking at too, in addition to residency slots. Thank you, Mr. Chair, for the question.
If I may just, Chair, just add one point. So, Senator Titus, when we mentioned the 5 programs that we're interested in standing up at UNR Med, 2 of them are fellowships. One of the residencies, OBGYN, could certainly benefit from the development of a maternal fetal medicine fellowship, but you need the residency before you can stand up the fellowship. And that's an area of great need in this state as well. So I think they go hand in hand, the development of new residencies and fellowship programs.
Thank you so much. I have 2 questions that have been brought up to my attention. I just want to make sure that I ask you, in talking about the other policy initiatives, I mean, we have obviously the fiscal questions that we will go through, and obviously GME is obviously something that we're always in discussion. Let's talk about some of the things that were passed last legislative session. Talk to me about some of the conversations you've had over medical malpractice, the cap being raised, and then how that impacts the academic institutions. Can you give us just your personal feedback on how your schools are dealing with it?
Mark Kahn, for the record. I'm going to let my colleague answer as well, since our systems are a little bit different. So our primary main teaching hospital is UMC. My colleague's primary teaching hospital is with Renown. So it's a little bit different. So I think that the change in malpractice has affected our faculty less than practitioners in the state because we're still covered by sovereign immunity. But clearly we have seen in other states, and it's almost reproducible, that as you raise the cap, costs for malpractice insurance go up and physicians start to leave the state. So although it doesn't directly affect my faculty, I think we need to be really careful, and we need to look at this very closely because we don't want to be in a position that we were in several decades ago. Paul?
Thank you, Paul Hauptman, for the record. I think it's a bit early to know what the impact has been on practitioners in the state since the increase in the cap just occurred at the end of the last biennium, or I suppose in the beginning of the new fiscal year. However, it's something that we'll continue to watch and watch closely. because it can impact physician behavior. And as you may recall, when testimony was given at the time of the biennium, there was a lot of concern about history repeating itself. I don't think that has happened. I think the initial proposals were rather draconian, and a compromise position was reached that seemed to satisfy both parties.
Great, thank you so much. With regards to finding folks that can mentor your students in terms of not just faculty, but the extenders in the community that could be affiliated with your universities, is there an interest in perhaps revising continuing medical education requirements in the state and including mentorship as part of that? Can you talk to us about that?
Mark Hahn, for the record, thank you for that question, Mr. Chair. I think that's a great idea. I think between our two institutions, we probably have 600 or so community faculty. And those faculty are critical to the success of your state medical schools. They teach medical students, they're involved with medical students, and we truly appreciate what they do. I think, when they prepare to make rounds and they're working with medical students, if we could get CME for that experience, I think it would be both important and appropriate.
Yes, thank you for that question. It's very important to us and our future that we engage our community faculty in the teaching of students. This is an area we spend a lot of time thinking about. I think there may be a number of creative solutions. CME is just one of them. There may be an opportunity to provide them with tax credits or some other avenue to encourage ongoing participation in the teaching of the students.
Great, thank you so much. Any last minute questions before we close out this agenda item? I know that, there's always so many questions that we can have. I know we didn't get the chance to talk about student retention, making sure that there's enough resources for them to go through your programs, making sure that undergrads are supported in their efforts to become pre-medical students and then actually retain them as part of the application process. And so there's obviously a lot more work that needs to be done, but I think it's important for us to have these discussions, and I think you probably could allude to that the policy recommendations that you had at the end are kind of the discussions we'll have throughout the day, including licensure. We had GME funding already in the morning, and so we'll obviously go through our process, but I think it goes to show, I've mentioned this before, it's historic to have both the deans here presenting together. We greatly appreciate your collaboration just in general of bringing ideas that can help steward our state forward, and it's always at least incredibly optimistic to see both of you here. I don't know if you have any closing remarks.
Thank you, and thank you for allowing both of us to answer your questions today.
Great, thank you so much. We'll go ahead and close this agenda item. We do have one more agenda item before we go on our break for lunch. I want to make sure that we have the folks from NCSL present, so we'll move on to agenda item 6, which is a presentation on general policy trends relating to childcare and housing, and an overview of policies to address healthcare workforce and physician licensure. So just a quick background. Typically, because of the nature of how we do presentations and so forth, I wanted NCSL to just come because they have obviously a lot of resources for legislators to understand what is happening nationwide. And so through this process, we can ask them what are some of the current policy trends, and then we can take that into consideration as we're going into the later half of the day. So please begin when you're ready.
Thank you, Chair Doñate, and thank you for inviting me to speak today. My name is Kelsey George, and I'm a Senior Policy Specialist with the National Conference of State Legislatures. My portfolio includes health workforce topics as well as emergency medical services, and I'm joined by my colleague Kelly Hughes, Associate Director of Healthcare. Now, I was invited today to share some state legislative trends that NCSL has identified in health and human services. Now, I want to start with a reminder that as legislators and legislative staff present today, you are members of NCSL. We exist to serve your legislative needs, including legislative tracking in a variety of databases, numerous policy publications, which are available publicly on our website, policy research to answer any of your questions, and presentations like the one that I am providing now. While NCSL is a partisan organization and our leadership alternates between Republican and Democrat every year, NCSL staff like myself and Kelly are nonpartisan, and we do not advocate for or against any state policies. So I want to start with a quick roadmap of what I'll cover today. We'll start with some health and human services policy trends, then I'll dive into health workforce trends, and we'll focus even deeper on physician licensure strategies that we're seeing from across states. I'll close with a couple of additional resources, and I'm happy to take any questions afterwards. Now, I want to note, for the sake of time, I'll have to breeze through many of these topics, but I'm always happy to provide more detailed information after today's meeting. There are also resources that are highlighted in teal boxes on each slide to provide that are a great place to start for more information. So with that, I want to begin with health and human services trends. Now, NCSL staff have identified many of these trends that I'll share today from our legislative databases and questions that we received from NCSL members like yourself. And I anticipate many of these will be familiar to all of you. Now, the word cloud on this slide summarizes questions that NCSL staff answered from legislators and legislative staff between 2020 and 2023. Given that time frame, it's no surprise that you'll see COVID-19 was a big priority among states. But I want to touch on a few other notable areas you'll see pictured here as well. Medicaid accounts for anywhere between 13 and 41% of state budgets, including federal funds, so it's a significant priority for states. NCSL's executive committee, which is made up of legislators and staff, identified behavioral health as a top issue for states in 2024. And given the severity of U.S. maternal mortality rates, many states are also prioritizing maternal health this year. And last but certainly not least, health workforce remains a top priority across many states amid shortages, high turnover rates, and bottlenecks in the educational, training, and licensure processes. More on this in a moment. For more on these topics, you can read our forecast special report, which is linked here. So now let's turn to the human services side. Childcare remains a priority for states. Legislators are considering how to incentivize employer-supported childcare through tax credits and deductions, cost-sharing programs, and grants. And many are also trying to expand eligibility for childcare subsidies and improve compensation and public benefits for childcare providers. States are also addressing housing through legislation. This includes strategies like regulating investor purchases of residential properties, taxing or registering short-term rental properties, expanding eviction protections for tenants, especially older adults, and incentivizing housing production and creating homeownership opportunities. NCSL staff also track legislation at the intersection of housing and health outcomes, and we continue to see states pursue strategies to support behavioral health and to assist older adults in aging in place. And you can read more in our forecast special report linked here. So with this overview as our foundation, I want to take a deeper look at health workforce trends. Now, we heard a lot of information on the challenges both in Nevada and across the country in the last two presentations, so I don't want to spend a lot of time here. But two of the main health workforce challenges that we hear, regardless of the profession or occupation, are shortages, meaning not enough workers, and turnover, or workers leaving the profession. Many workforce shortages are exacerbated by recruitment and retention challenges. These may be financial, educational, or workplace challenges. And one profession I want to focus on here is behavioral health. So you'll see the map on this slide shows provider to population ratios for behavioral health specialists. Darker colors indicate more providers per 100,000 residents, and lighter colors indicate fewer providers and more likely shortages. And you'll see Nevada is in a light yellow color, and many Nevada counties have 0 behavioral health specialists based on this tracker from George Washington University. Another challenge we're seeing is turnover rates. Retention, or ensuring that existing workers stay and grow in their professions, is critical to addressing workforce shortages. The graph on the left shows estimated turnover rates. You'll notice that all settings across long-term care, ambulatory care, hospitals, and others experienced increased turnover rates from the pre-period, or 2019, to the post-period 1 in 2020. Now, one profession I want to highlight here is long-term care. And while other settings have returned to their pre-pandemic rates, you'll see that turnover continues to increase in long-term care. NCSL maintains resources on these health workforce topics and more, which can be found through the link on the slide. Now, with that bleak landscape out of the way, let's turn to something a little bit more hopeful. What are states doing to address these challenges? When we talk about health workforce, I like to start with a simple question. What data, research, and expertise can we use to understand the health workforce? Now, we see states are moving beyond counting the number of licensed professionals to understanding who is providing what services, to whom, and where. Several examples are highlighted on this slide. So you'll see states are gathering data in long-term care, like Colorado and Florida. Georgia and Illinois established data collection for behavioral health professions. And Indiana and Utah established systems across all health professions to collect information during the licensure process. Now, Nevada has many similar systems in place, including the state's Health Workforce Research Center and the Home Care Workforce Employment Standards Board. Data collection and analysis, as I'm sure all of you are very aware, are critical to the policymaking process and may provide a baseline to compare policy interventions against. So I want to start first looking at recruitment. And the largest trend that we see here among states is career pathways. Career pathways create a pipeline of qualified individuals who are ready to fill in-demand healthcare jobs. And you'll see a few examples on the slide here. Colorado established a pathway program in 2015 and established new pathways that specifically focused on behavioral health between 2019 and 2020. And as I mentioned in the last slide, Indiana required health workers to report certain data during their licensure renewal process beginning in 2018. And their largest community college, Ivy Tech, established a CNA Bridge program for direct care workers based on the information gathered. And Nebraska established a program to incentivize local high school graduates to pursue healthcare careers in rural areas within the state. Now, I also want to note here, Nevada has several pipeline programs that exist across the state as well. And you can read more about career pathways at the K through 12, community college, and post-secondary level at the report linked on this slide. Now, to address turnover, many states are turning to financial incentives. These may include things like loan forgiveness and repayment programs or tax credits and deductions. Many of these programs were originally established to address physician shortages. And today, some of these are being expanded to address other healthcare workers, like behavioral health professionals or direct care workers. Most of these programs have a practice requirement of some sort. So to be eligible, health workers must commit to practice within the state for a certain number of years. And as you can see from the examples on this slide, the dollar amounts and requirements for each incentive vary greatly. Now, finally, I want to share a couple of emerging topics that NCSL is closely tracking within health workforce. The first is emergency medical services. EMS has historically sat between transportation, public safety, and healthcare, and we have seen an increase in EMS legislation across all of these areas. NCSL maintains an EMS legislation database, which is linked on this slide, and some of the most common themes from enacted legislation that we see there include declaring EMS as an essential service that governments must provide, allowing reimbursement for community paramedicine or care that's provided by EMS clinicians within the community, adjusting licensure age requirements to allow high school students to complete training and certification as emergency medical technicians, and creating financial incentives like retirement or health benefits, tax incentives, and loan repayment or forgiveness. Now, I know we're discussing this topic later today as well, and that Nevada shares many of the EMS challenges that we're seeing across the country now. Another emerging topic that I want to touch on is artificial intelligence. Now, this is a growing topic, and several states have proposed legislation specific to AI's use in healthcare. And I want to note that this is a very new area, so we're not seeing very many enacted bills, but we are keeping a close eye on legislative actions. As you'll see on the slide, more than 115 bills have been proposed on AI topics generally so far this year. And in 2023, we saw at least 11 states consider legislation on the use of AI in healthcare settings. Now, some common themes in proposed legislation relating to health include monitoring or preventing discrimination in the use of AI, setting provider monitoring and review requirements, ensuring transparency for patients when AI is being used. And AI has the potential to alleviate some workforce challenges, like burnout. The average nurse spends about a quarter of their time on administrative activities, and this is one area where AI may build capacity. Research suggests that more than a third of administrative tasks could be automated by AI and decrease human error. Now, finally, I want to take a look at state actions on physician licensure. The American Association of Medical Colleges has predicted significant physician shortages within the next decade, and Nevada continues to see low physician-to-population ratios in primary care, general surgeons, as well as specialties in pediatrics and psychiatry. Now, some common challenges that we've identified within physician licensure at NCSL include processing times and portability. So I'll begin first with processing times. The American Medical Association suggests that physicians allow at least 2 months between submitting an application and receiving official licensure in most states. However, wait times may take as long as 6 to 9 months in some states. Now, I want to note that state-specific data on turnaround times is often not publicly available, or it may not be tracked due to limited staff capacity. And I understand the Board of Medical Examiners will share some Nevada-specific data later today. The table on the right is the closest I could come to finding an example of nationwide data, and this comes from the Interstate Medical Licensure Compact, of which Nevada is a participating member of. And the data on this table notes that even as applications increased, as you can see from 2018, 2019, 2020, the number of days from application to when licensure was issued were maintained. Now, across states, some commonly cited challenges for licensing processing times include paper-based applications, increased licensure applications due to the COVID-19 pandemic, background check and fingerprinting delays, and staff capacity. And in the next few slides, I'll share some examples of how states have addressed these challenges. Now, several states have recently moved from paper to online applications, Nevada being one of them several years ago. And California, one example, identified its paper-based procedures as a barrier. They expedited the online application development process during the pandemic as they saw increased applicant volume. California piloted their direct online certification submission system with several medical schools, and this removed physical barriers to licensure, like getting access to notaries, school seals, and other things. They also established an online verification system for continuing education, which expedited licensure renewal processes. Another example is Wisconsin, and they identified many of the delays that they were experiencing were due to missing paperwork throughout the process. They developed an online platform that allowed applicants and employers to monitor the progress of their applications throughout. After implementing this, turnaround for applications decreased from 90 to 30 days. And discussions are still ongoing within the state on how to address remaining backlogs. The governor has proposed the agency keep revenue from licensing fees to hire additional staffing to create more capacity, and the legislature is undergoing an audit of the agency currently. Now, state requirements for state and federal background checks vary. While background checks can serve an important role in ensuring patient safety and quality of care, they may also create barriers to licensure. Background checks are required in most states and territories for medical professionals, as shown on the map on this slide. And you'll see a handful of states do not require background checks, and at least 3 do not require fingerprinting or federal background checks. Nebraska is an interesting example that I want to note here. Recent legislation required the state to submit fingerprints to the FBI for medical licenses, causing delays in at least 100 applications from being approved in certain professions. Now, to address this, the governor signed a temporary executive order that allowed state patrol to conduct federal background checks instead, and this cleared that initial backlog. And the legislature enacted a bill in 2023 that allowed state patrol to process these background checks permanently. So beyond processing times, portability is also an important consideration for states. This refers to the ability of health workers to practice across state lines. Now, policy strategies under portability may include temporary or emergency licenses, which we mostly saw during the pandemic, reciprocity or endorsement, which we mostly see through interstate licensure compacts, and the state's ability to waive certain requirements for licensure. NCSL maintains a database of recent occupational licensure legislation, which is linked here. Now, we saw many states implement temporary or emergency licenses like Alabama and Maryland pictured on the slide during the public health emergency. And these were often done through temporary rules or executive orders. Since the majority of these have expired, I'm not going to spend a lot of time unpacking here. But next, I'll move to reciprocity. And as I mentioned, the most common action that we see from states here is joining interstate licensure compacts. The Interstate Medical Licensure Compact facilitates interstate practice for physicians, and Nevada is a member. You'll see several other health-related compacts on this slide as well. And it's important to note here that each compact has different requirements, governance structures, and restrictions. The Council for State Governments maintains a National Center for Interstate Compacts, which is a great source of information here. And a summary of NCSL's recent session at one of our meetings on interstate compacts is linked here. Now, states may also establish reciprocity agreements with neighboring or similar states. And one recent example I want to highlight here is the DMV reciprocity pathway in purple for physicians. And this allows them to practice across DC, Maryland, and Virginia. Now, telehealth emerged earlier in our conversations today, and I want to note that while Nevada and many other states require full licensure within the state to provide services via telehealth, some states have created limited licenses to create an expedited process and increase access to care provided virtually. So one example is Idaho, which does not require a license for virtual care when a physician meets certain requirements, and this includes consulting with an Idaho licensed provider. Another example is Arizona, which does not require a license for telehealth services if the physician registers with the state annually and meets other requirements. So lastly, states have the option to waive certain requirements for licensure. And during the COVID-19 pandemic, we saw this for a variety of healthcare workers. Post-pandemic, however, we mainly see this relating to international medical graduates. Most states have unique requirements for international medical graduates, including ECFMG certification, residency requirements, and language competencies. Now, policies for international medical graduates often emerge at the federal level, unsurprisingly, but states have several policy levers here too. So you'll see some states, like Colorado and Minnesota, have established support programs to help international medical graduates address barriers and complete licensure requirements. Other states, like Idaho and Tennessee, establish temporary restriction or licensure for international medical graduates who meet certain requirements. Now, we've talked a lot about graduate medical education so far today, but I want to note that another bottleneck in physician licensure for both international and domestic applicants is GME. And historically, GME has been funded through Medicare. But states also have leverage here through Medicaid and state appropriations. Now, some examples are included on this slide. Florida and New Mexico have leveraged GME funding through Medicaid to expand residencies for specialties and non-traditional residency sites like federally qualified health centers. And I want to note here too that New Mexico's approach has been informed by their GME expansion 5-year strategic plan, which was developed by the Human Services Department in 2019. On these Medicaid examples, I also want to note that states may leverage a variety of authorities under Medicaid for GME funding. And this may include hospital base rates or supplemental payments to teaching entities. We just heard an example of, or heard more information on Nevada's GME grant program from OSID a moment ago, but I also want to highlight Iowa has appropriated state funding to start new programs, which is a cost that's typically not covered under Medicare reimbursement for GME. Not included on this slide, but of note to our conversations today, many states have also created coordinated statewide GME initiatives. This includes Oregon, which has a residency collaborative alliance for family medicine, and Colorado, which maintains a family medicine residencies network. And these exist to provide ongoing technical assistance to program directors and to new programs within the state. So many NCSL resources are linked here and throughout my presentation for future reference. And my contact information is also available on this slide. Please reach out if any questions emerge after today's meeting. And with that, I want to thank the chair and the committee for having me. And I'm happy to answer any questions.
Thank you so much, Ms. George. Any questions for committee members? Assemblywoman Bromley.
Thank you, Ms. George, for that great presentation. Really appreciate NCSL and the nonpartisan information that you provide. It's always great. Medicaid funding. You have Florida appropriated $97.3 million. We know what Nevada is doing. I'm curious to know, are there additional federal match dollars available that we have not considered to date that could help us fund graduate medical education or other positions that we're just not tapping into that you're aware of?
Medicaid at rural emergency hospitals, which is a new facility designation. So that's one new example that has come up within the last year or so that we've seen. But I'm happy to follow up and send more information after.
Any other questions in Southern Nevada? Northern Nevada? I don't see any. I know we're all just digesting the information. I have a quick question regarding, so I know we just asked about GME funding. You know, the licensure portability measures, can you talk to us about, I know you talked about Arizona and Idaho. So last time we had NCSL present during the last interim, we talked about telehealth parity and some of the initiatives and trends that certain states are doing. So can you discuss more about those initiatives? Or are we seeing more recently that we're being more flexible to help ensure access to care? I guess if you can just go over a little bit more concretely on these two initiatives.
Note that during the pandemic, we saw nearly every state and territory alter their telehealth regulations in some way, either through executive orders or through legislation. And we continue to see states, as you mentioned earlier, make some of those changes permanent or to adjust back to pre-pandemic rates. And so far this session, we've seen at least 1,000 bills that have been introduced on telehealth alone. And some of the biggest trends that we see are that cross-state licensing, like licensure compacts that I mentioned, allowing online prescribing and patient-provider relationship establishment requirements. We also see a lot of activity within telehealth on reimbursement policies, expanding access to broadband, similar to the conversation we had this morning, and some pilot programs and regulatory and licensing issues. And those are similar to the examples that I gave from Idaho and Arizona of either temporary or waiving certain licensure requirements for physicians that are licensed in other states to provide telehealth to patients who may be located within the state.
Great, thank you. Any questions before we close this out? Seeing none, we greatly appreciate the resources that you have provided. I know there are a lot of different policy initiatives, and we're excited to start talking about them later on after today's and the final agenda item. And so we greatly appreciate you and, of course, all the work that you do for federally and nationally as well. So thank you. We'll go ahead and close this agenda item and then, so just as a guidance for where we're at, so we have a few more agenda items to go before the end of the day. We're going to go ahead and take a break. I know our legislators need to go eat and go to the restroom, so we'll take a break from now until 12:20. The agenda items that I will do in order after this are agenda item 8, agenda item 10, agenda item 7, and then agenda item 11. And I think the last one will be agenda item 12. All right, again, that's 8, 10, 7, 11, 12. So we'll go ahead and recess until 12:20, so feel free to go use the restroom or anything, and then we'll be right back. Thank you so much. Welcome back, everyone. We'll go ahead and get started. I know a few of the committee members are still making their way through and folks coming back into the committee room. We will go ahead and start with agenda item 8, which is an overview of medical licensing processes and provisional licensure, potential barriers to licensure, and future considerations. With us today, we have Ms. Bradley, who is the Deputy Executive Director for the Nevada State Board of Medical Examiners, and Dr. Spiritos, who is the Board President. So please begin when you are ready. The mic, please.
There we go. I was like, it's not lighting up. Thank you, Senator Donate and members of the committee. I'm going to go ahead and start and do the presentation. Then Dr. Spiritos has a couple comments to make when I'm done. Also in Carson City, just so you know, we have Corey Lynn, who is our Chief of Licensing, here to help with questions if I can't field them. And also Mr. Clark, our lobbyist, is also here. So the board issues 5 license types on a big level. So obviously medical doctors is the one that I think gets a lot of attention. Also physician assistants. With regard to medical doctors, we have obviously the active unrestricted license. I'm not going to go through the whole list, but I did want to highlight for you that we have a special purpose license that's for telemedicine. And so anyone with that kind of a license agrees that that's how they're going to practice medicine in Nevada. Otherwise, they would have an unrestricted. Doesn't mean unrestricted can't do telemedicine, but special purpose is just that kind. Physician assistants, we also license. Practitioners of respiratory care, perfusionists, and our new category is anesthesiologist assistants, and I'm excited to say that we have 3 active anesthesiologist assistants now, and we're thinking we'll get more this summer as hospitals start, people graduate and they give offers. So first, for an overview of the licensure process, the first step that we know that the application is there is when an applicant submits their online application form and pays the application fee. And I highlighted that because sometimes people will start things in the portal. We have an online portal. They'll start it ahead of time, but until they actually click submit and pay the fee, we're just waiting. You know, we don't know that they're there. And so sometimes I think people think they've started and they're still just entering information. Once that's done, the applicant's file is opened, initial reports are run, and the file is given to a license specialist. They're assigned by last name, and so everyone that's on our website, that they look up their last name and they can find out who they should be speaking to, and that person will work with them throughout the process. The license specialist reviews the applicant's file for eligibility. If they're not eligible, the way that they've initially submitted, the license specialist will communicate with them regarding other licensure options such as endorsement or other things that might work better for them than perhaps the more traditional route. If an applicant is eligible for licensure via their initial submission, the license specialist opens the applicant's application. The applicant then receives by email an acknowledgement packet. And this says essentially, thank you for your application. I'm your licensed specialist. And it also includes information on fingerprints, which we are now doing electronically, which is a new exciting thing for us. And we'll talk about that more in a minute. The license specialist stays in contact with the applicant in order to obtain all necessary documents and verifications. So as you can imagine, it's important to verify schooling, postgraduate training, things like that are really important. Once an application is complete, it's submitted for a final review. That's just a double check to make sure that everything truly is there. Once that's approved, then the person is told your application has been approved. Please log in and pay your registration fee. And then once the registration fee is paid, the license is issued. The Interstate Medical Licensure Compact is really important to Nevada. We are getting approximately 50% of our new medical doctor licensees through the compact, and so we wanted to talk about that. This is an expedited pathway to licensure for physicians from in multiple states, and Nevada was one of the first states to join the compact, and so I think we were state number 9. Licensure in Nevada is 1 to 3 business days on average through the compact. Now, not every single person is always eligible. They have to come here, they have to have a state of principal licensure essentially sponsor them. So it's that other state that's a member. And here's the member states for you. So the ones that are in that dark blue color, the navy blue color, those have SPLs and they're full members of the compact. And so that's 32 states right now, and it's growing. Some of the other states that are also in blue and lavender, they are in the process of getting going with the compact in order to allow more options. And then the gray states, they're not in the process yet. So the total licenses we issued last year in 2023 was 2,072. Of that, 1,688 were medical doctors, unrestricted, and as you can see, it's 839 through the compact, so that's a little less than 50%. I think it was like 49% when I did the math. Special event licenses, we had 6, and then special purpose, we had 5. And again, the special purpose is the telemedicine license. It's not required. You can do telemedicine as an unrestricted, but only special purpose only can do telemedicine. Special event licenses are for special shows and things where there's a demonstration or sort of a limited duration of practice in Nevada for a special event. Physician assistants, 175 were issued. 8 of those were simultaneous with the Board of Osteopathic Medicine. The legislature might remember that back in 2021, we started doing simultaneous licensure with that board, and it reduces the application fee for the PAs. Practitioners of respiratory care, 166. Perfusionists, we had 24 unrestricted last year, 7 temporary. The temporary, they're waiting for their exam and their certification. And then there was 1 denial, and that was actually a practitioner of respiratory care. That was not a physician that was denied last year. Average licensing times in 2023. For medical doctors, the average, including through the compact, so this is our total average, is 86 days. And that's from the date that they push their submit button and pay their fee to the day the license is issued. The fastest licensing time that was not a compact person, because as I said, that's 1 to 3 business days. Obviously, it's pretty fast, or can be. The fastest non-compact last year was 22 days. Physician assistant, 116 days on average. Practitioner respiratory care last year, 146 days. And then perfusionist was 127 days. And last year, we wanted to note that last year was a renewal year. So more than 14,000 license renewals were also done last year by staff, including almost 11,000 medical doctors. And that's all done in less than 3 months. And so sometimes that does, as much as we don't want it to, doesn't make our days, we're kind of busy during that period. And we're working as fast as we can. We did want to talk about residents, and I know that's been one of the conversations today. So with few exceptions, all residents expire each year on June 30th. So this is a yearly thing. Right now, we have 534 practicing in Nevada based on the new ones we issued last year as well as the renewals. 9 institutions in Nevada offer approximately 64 accredited programs. We said approximately because sometimes it can vary, and I think you heard about that today. A new program will open or one will close, things will change. And if a medical doctor, this is the research we had, if they complete their residency in Nevada, they are, according to the American Association of Medical Colleges, 52.3% is the number they actually publish. And you can link, there's an active link for you there. That's the number they publish for Nevada. So that's what they say will stay in Nevada if they complete here. And then that American Family Physician, we just thought it was kind of interesting, was an article saying 56% of doctors practice within 100 miles of their residency. So far, and this is just the first 2 months of 2024, so this is through February 29th, we have 441 new licensees. We have 339 unrestricted medical doctors, 152 through the compact, 1 special event, 1 special purpose, 72 physician assistants, and 20 simultaneous with the Board of Osteopathic Medicine. 24 practitioners of respiratory care, 1 temporary perfusionist, 3 new anesthesiologist assistants, and so far there's been no denials this year. So here's a snapshot. I know this was one of the things that was requested. So just know these numbers change actually throughout the day. So at the time that we compiled this, there were 48 approved applications waiting for registration fees. That's going to fluctuate throughout the day. Maybe by the end of the day, half of those folks had paid, but we described it right then. 5 applications were complete, waiting for final review and approval, and we had 462 applications open, waiting for the applicants to submit their materials. So far in 2024, our average licensing times has been 49 days, including the compact, so the total average 49 days. Fastest licensing time not through the compact, 15 days. Physician assistant, 66 days. Practitioner of respiratory care, 82 days, and perfusionist, 29 days. And I will talk about, we've really been working hard to make changes to make these times faster. And so we'll talk about reasons we think that is right now. So we opened an online application portal January 1st, 2021. Before that, all of our applications were actually processed through paper. And we think this is obviously a good thing to be doing this electronically. So that has been some changes we've needed to implement and work on and refine, but we're excited that we have that. We also have a new chief of licensing as of February 2023. She's doing a great job, and I think it's been really helpful to have somebody who is new to the position really look at things and ask, why are we doing this? What can we do better? How can we do it quicker and more efficiently? And so we've really been working on that. Effective February 13, 2024, applicants can submit their fingerprints via live scan. And so that's electronic fingerprints, which is a big change. Now, this is not a change that we were able to implement by ourselves. We had to work with the Department of Public Safety. And again, it's only people in Nevada. So this would mean if they're an applicant out of the state, they can come to Nevada and get a live scan, but they're not allowed actually to do a live scan in another state. And that's not our rules. But it's still very exciting that we can do live scan. And then last year, June of 2023, we started implementing a lot of changes after reviewing our processes and our new chief, as well as talking to the Federation of State Medical Boards, which is essentially an association of all the state boards in the country. We had some staff from them come out and audit our processes and look at what we're doing and make some comments. So all initial correspondence and fingerprint instructions are being sent via email. We used to send those by regular mail. We now accept a notarized copy of an identity document rather than the applicant sending the original. And that, as you can imagine, was some delays. And there were also, was an important document for us to track. And so this way they're sending us a copy that's notarized. Only one addendum is requested at the end of the process after all verifications are received. And the addendum is really additional explanations from the applicant regarding various questions. And so instead of, in the past, they may have done an addendum for each one, now we just do one at the end with everything. We use the Federation of State Medical Boards Physician Data Center to do a report for medical doctors and physician assistants. That helps us verify their license information in other states, and we don't need direct source then from the other state boards because the Federation has already got that. That's how they've entered it in their system. So it saves us a lot of time, and it saves the applicants a lot of time as well if they're licensed in more than one state. We no longer require direct source verification of clinical rotations for island or Caribbean schools. The ABMS, and this is that American Board of Medical Specialties. We heard talk today about board certifications. So these certifications are now going to be verified electronically by the licensed specialist, and we're not having the applicant send those to us. We no longer require proof of observership or research positions. Many unnecessary and redundant questions in the application addendum were removed. So we went through that and lots of things that we really felt were outdated and are not necessary were taken out to simplify the process. Applicants need to only provide a summary of their activities for 5 years preceding the application date or since graduation from medical school or other post-secondary school related to their licensure if their graduation was less than 5 years ago. We actually used to ask everyone all of their activities since graduation. And for some folks, that was a long time. So now we're just going back 5 years for everyone or less if they're a newer grad. Malpractice documentation must only be provided for cases within the last 10 years. And so again, that shortens the time period for information gathering for our applicants. Arrest documents are no longer required of applicants unless they are appearing before the board in connection with their application. So this would mean if they're going to appear at a board meeting and the questions are related to a criminal history, that's when they have to provide those. Otherwise, just because they say yes, for example, to having a conviction in college for DUI or something like that, we're not requiring documentation for that. Multiple changes have been made to staff processes that allow the licensed specialists to work more quickly and efficiently. Staffing changes in the licensing division. Since January of 2023, we've added 3.5 full-time equivalent licensed specialist positions. And again, these are the folks that really deal with our applicants and talk with them all day. That's their job, is to work with our applicants. And so we have more staffing there to work with applicants. 2 licensed specialists are dedicated to the compact application. Those are a little bit more streamlined and simple, which is why we only have, 2 is still an increase, but we do have more licensed specialists that work with the traditional applications. And then additional licensed specialists are trained in the final review process and resident licensure process, because as I mentioned, we do that every year. That's about 500 either issuing or renewing, and that takes some time. And so we have additional people that can help with that than we had in the past. We do have some regulations and process that are going to help streamline application process for all license types. I've given you those numbers. Essentially, the changes we're making is things about residents. So for example, we used to ask about the resident's address going back to essentially graduation from high school and then forward. So now we're just asking, all we need is a permanent address for our applicants, permanent mailing, and a mailing for the board and then a public address that'll go on our website. So we just need 2 addresses that are current for today. We've also reduced staff turnover in the licensing division by implementing the staff raises and bonus structure that the legislature adopted last session, and we were really excited to do that to help with retention. So coming changes to licensing efficiency. This year we will be getting an updated licensing software. So this isn't something that we're totally able to control ourselves. We've been being told for a little while they're going to upgrade us, but wow. Right now, our anticipated date is September 2024. We're really excited about these changes because I think it will really update the process for both licensed specialists and the applicants. The applicants will be able to communicate securely with staff through the system. Rather than like sending emails or calling, they'll be able to actually send like a secure direct message and upload as well documents directly into the system. It also will provide other enhancements to the applicant and licensee portals. So while they're applying, they have this portal to get their application together. And then afterward, they can log in, for example, to change their address, things like that. So licensees still use this portal later to provide information to the board, change their address, et cetera. They can also upload CE certificates, CME certificates. And so that will be more robust with the new upgrade. And again, we're hoping to have that done Labor Day, where is the kind of the target time frame, kind of depending on our vendor, but that's what they've told us as of today. We are adding a new staff member to focus on IT improvements because we do want to increase that ability at the board. And so that person will be full-time helping with IT issues and improvements. We are working on application instruction videos on the board website to aid applicants. And so we'll actually have some of our staff talking about essentially what they need to do, click this button, do this. And so it'll be instructional. We don't have those live yet, but we are working getting those live. We also want to work with the OCIO to revamp the board website. As you're probably aware, in some ways, the design of the board website isn't totally up to us since we do work with the state IT and there's certain templates that are available, but we want to do our best to revamp it and make it as easy to find information as possible for applicants and the public and licensees. And we're working on continuing to empower our board staff to suggest and implement changes that will allow us to improve our efficiency in licensing. Again, I mean, we're really proud of our staff, and obviously they're doing this every day, all the time. And so sometimes I think the best ideas we can get are from the people that are doing it on how to make things better and faster. And so we're really doing that. Here's some perceived board-related delays to working in Nevada. So one thing we wanted to have you all keep in mind is that other entities, such as hospitals, often won't begin their credentialing process until someone's licensed. So someone may move to Nevada, but they may not be able to work for a longer period than it takes them to get their license because of that credentialing process. And that's not something we have control over. And so I think sometimes people maybe blame the board or they're upset about the delay. But really, and then I guess our process often comes first, and then the credentialing process will be second. Nearly 75% of the time to issue a license is related to applicants obtaining the proper documentation. And this is something that came out in the legislative audit. And again, I have a live link to you there, for you there. Again, we can't control that. And, and in my mind, we need time to process it, and we're trying to do it as quickly as we can, but if we're waiting for responses and waiting for information, that slows it down. So a recent example we had was an applicant took 4 months to provide additional information regarding an undisclosed arrest. And, and that's going to delay that application. Things like that happen. I mean, it's not uncommon to message them and not hear back. We try to follow up, and our staff does that regularly. They flag them for continued follow-up, but we're not in control of that process. The other thing is this idea, and I mentioned it early on, we don't know the application is there until they've hit submit and paid the fee. We have talked with folks in the past who have said, my application's been pending since X day. Well, actually, no. You may have started entering information in the portal, like your name or things like that, but you didn't actually submit it for multiple months after that. And that happens. And I don't really know why that happens. I do know it's a process sometimes to gather things, and maybe a savvy applicant would start to put things in the portal before submitting. But I know we've heard it attributed to us when we know exactly when they submitted and paid their application. We were asked to talk about potential bill draft requests that we might want to see. The first one is we would like to do a cleanup. We're still gathering some statutes that we think might need some cleanup. I kind of keep, it's one of the things I do is I keep a list of those to make sure that we're being updated with regard to changes. I know there's one statute that did not get anesthesiologist assistants added to, and I want to make sure they get added to that. And then a few other changes like that. And then we wanted to talk to you about the continuing medical education requirements for doctors and physician assistants, because it's kind of confusing, and we think it can be burdensome, and perhaps it's something that this committee and the legislature in general may want to address. So all medical doctors and physician assistants have to do 40 hours every 2 years of continuing medical education. But a lot of those hours are spoken for by different legislative enactments, and some of them are even a little bit confusing because they're duplicative. So the first thing is extra credit is given for CMEs in geriatrics and gerontology, effective management of medications, and diagnosis of rare diseases, including pediatric cancer. So there's a statute that says the board is to encourage people to take those courses. There's a reg in place already on geriatrics and gerontology and the diagnosis of rare diseases. We have one that we're going to be bringing regarding the effective management of medications, because we don't have a reg giving that double credit yet for that. And then 8 hours is required in the first 2 years of licensure in the areas there on that slide. So 4 hours in acts of terrorism and bioweapons, 2 hours in evidence-based suicide prevention and awareness, and then 2 hours in screening, brief intervention, and referral to treatment. So everyone has to do these at the start of their application. At the start of their time in Nevada. So they get licensed. Their first renewal has to include those 8. And then afterward, every 2 years, they do the ethics, pain management, or addiction care. But then this is where it gets kind of confusing. So if they're registered to dispense controlled substances with the Board of Pharmacy, Then they have to do misuse, abuse of controlled substances, prescribing opioids, or addiction. My understanding is most of our physicians are licensed to dispense, but not all. And that's not something that we actually give them the authority for. So they would have to know, oh yeah, I'm licensed to dispense, so I have to do this one. And then 2 hours of cultural competency and diversity, equity, and inclusion. This is only for psychiatrists, MDs, and PAs working under supervision of a psychiatrist. And then again, we have the screening, brief intervention, and referral to treatment. This is only required, and I think it's for everyone that didn't get it in the first step, the first 2 years. Everyone else has to do it by this coming renewal in 2025, just one time. And then every 4 years, so it's every other renewal, everybody has to do a suicide detection and intervention and prevention class. And then this new requirement is required as of 2025 renewal. And this is 2 hours on stigma, discrimination, and unrecognized bias toward persons who have acquired or at a high risk of acquiring human immunodeficiency virus. And so this is, and again, it's going to be a lot of our licensees because this is for everyone in the emergency medicine and primary care setting. So I'd say close to half are going to have to do this. So as you can imagine, I think it's hard for the licensees sometimes to know what they need to do and when. And we try our best to communicate that to them. But also it's harder for our staff when we do renewals to figure out, okay, we don't audit every single one or else we would never be done, but we do audit a percentage. And so we have to figure out, okay, it's this person, it's their first renewal. Okay, so then they have to do these. And then, they work for a psychiatrist. Okay, they've got to do that. And so it just can be challenging. And so I don't know if there's a way to make that more simple. Because that would be a request that we would have, I think, from this committee. And I have no further information, and I'll turn it over to Dr. Spiritos.
Thank you very much. I would like to add just a couple of points to what Sarah has mentioned, and I'd like to first point out to everyone what an incredible job that Mr. Cousineau and Sarah and the entire staff has done working towards the goal of shortening the time of licensing and modernizing the system. That being said, I'm going to first address the issue on the CMEs. Not only is it confusing on the licensing part, but it's detrimental in terms of getting a license when you start reading through the requirements, where we are one of the few states that have this kind of detailed requirements of our licensees. And in particular, we're one of 2 states that require training or CME in acts of terrorism and use of weapons and biological weapons of mass destruction. Suicide prevention, we're one of 7 states that have such specific requirements. And I would ask not only that we have the ability to clean up these bills and simplify the rules, but also leave it more to the discretion of the specialty boards that require. We also have certain requirements within each specialty board of CMEs that we need to have within our specialties, so that the legislators in Nevada periodically decide what is good for the medical practitioner. I think we need to look the other direction and simplify that code or those codes, the NRS, and allow the physicians to direct more of their CME. In terms of physicians and how do we incentivize or make this a state that is more likely to encourage the physicians to come here to practice. We've heard a lot of multiple discussions today about the cost, the impact of our medical malpractice changes. And I think there would be some consideration, given that there are 600 physicians who are working as clinical faculty members. Maybe consideration should be given to those physicians also being considered under the reduced level of the Pain and Suffering Act, so that the cap would be reduced, or we would be, those who are acting in a clinical capacity would be treated similarly to the full-time faculty members. I'll give an example. At the Women's Cancer Center, we teach resident and medical students on a daily basis, so full-time in essence, but we are not subject to reduction of our cap as well.
that might make it a little more enticing for people to contribute and be part of the clinical faculty at the various institutions. The other discussion I think we should have at some point is restrictive covenants. Physicians who are practicing in the state, who may want to leave and go to another employer, cannot always do so because there's a restrictive covenant in place. So you have the situation where physicians are currently practicing or present, their families are here, but if they have a, for lack of a better term, disagreement with their employer or feel they have a better opportunity across the street, they're not able to pursue that because of a restrictive covenant, and then therefore they have to look for out-of-state employment, and that causes another reason why we might lose physicians. That is probably those are the most important things, but I think those would be changes that could make Nevada a place more likely to either stay or come to in practice. That's all I have to say. Thank you. I think we'll be open for questions or comments.
Great. Thank you so much for that presentation. And of course, thank you to the staff for preparing this. I know that when working with the committee staff, I had requested a few bullet points and a few numbers. I know probably all of us will have questions, and we're very eager, of course, to dive into the issues. And of course, also to Dr. Spiritos for your service serving on the board. I want to just start my round of questions just to set the parameters for the discussion, and then afterwards I can let the committee members free for all and go afterwards. Okay, so the reason why I wanted this presentation is, as we have alluded to in our discussions today, oftentimes licensure is can become a barrier with our ability to practice in this state. We had the presentation from NCSL that notated that it's important for physicians, or there are states that are considering physician licensure as a priority. We saw the legislation in Idaho and other states of trying to make expansions and trying to reform how licensure is done. And then there's also this consideration of the timeline that it takes for us to recruit physicians from other states to start practicing, whether they're faculty at the universities or elsewhere, right? I think there's a request from at least the folks in our community that this needs to be done faster. We already have a problem with physicians not being in here in general, and so we need to make sure that we equip you all with the right resources to get this done now. And so let's start with just the baseline question. So I am an applicant. I just completed I completed medical school. I completed my residency program. I am done with my schools of training. I am finally ready to be a doctor. I submit my application to the Board of Medical Examiners. After that, it's under my interpretation. I don't have any work history, right? I obviously don't have any malpractice claims because I haven't fully practiced yet. And so application is submitted. I believe I've submitted everything correct. On what percentage do you usually follow up with applicants once the application is submitted? Is it like 90% of the applicants usually will require to relook at their application, or like what does that process look like as they're going through the pipeline?
Sarah Bradley, Deputy Executive Director. I'd actually ask Ms. Lynn if she's available to give us an idea on this question, because I understand what you're saying. My understanding, and she can clarify more, is that it's people with malpractice history and other kinds of incidents that they have to disclose and we have to verify that tends to be more of a delay causing situation, but I'll have her clarify further.
Good afternoon, Corey Lynn for the record. So what Sarah said is correct. It's malpractice, things like that. Residents can be sued for malpractice. It's not common, but sometimes if they're in their residency, they can be included in a lawsuit. So that does come up. Additionally, many applicants make errors on their application. So they'll get their medical school information, dates or whatever it might be, incorrect. And we won't know that until we get their verification and transcripts. So things like that will come up, and generally those are pretty quick. New applicants, or new graduates, I should say, are generally pretty quick to license. We very often do those in less than a month. And as the audit stated, the vast majority of that time is just waiting for verification of their medical school, verification of their postgraduate training that they've completed it. If they had any discipline or probation in their postgraduate training, that has to be addressed. Arrest history can come into play very, very often. And then additionally, if there's anything they didn't disclose. So for example, if their fingerprint results come back before they're licensed and it turns out they were arrested and never told us about it and answered no, then that's an issue that we have to address. But pretty much every application has an addendum that needs to be done. They can be very, very quick. Most of them are. If they just read the directions we send, we try to be very specific and careful about how we word our correspondence with them to make it very clear what needs to be corrected. And then if they send that back, it's a very quick process.
So just to clarify, in general, we can expect that every application that is submitted will need some further follow-up. Is that a fair assessment?
That is correct. Sorry, my name is Corey Lynn for the record. So once they hit the submit button, we get back to them almost 100% of the time within the week to tell them exactly what the next steps are, how to fingerprint and everything like that. And so there's always going to be some sort of follow-up because they need to get fingerprints done, so we give them instructions on that. There's application forms they need to sign. They need to do a waiver for the Department of Public Safety in order to get the fingerprints completed. And then we'll notify them of the verifications they need to request of their medical schools and postgraduate training. And then furthermore, seasoned doctors or who've had malpractice, we'll guide them on what the steps are for that as well. But we follow up with 100% of them, and it's almost always within the week, especially with our new process of getting in touch with them electronically rather than mailing their acknowledgement packet.
Thank you. And I just want to, again, I'm asking these questions on purpose so that it can help the committee members in their flow of ideas. Why isn't that just being requested at the time of application then? If you're going to follow up with them, why don't you just request that as part of the submission that is being considered in the first place when we have the applicant's attention?
Corey Lynn for the record, we do give that information on our website, and it is part of the application directions. So before they even get to a screen where they can input information, there are directions on the kinds of verifications that are going to be needed, where they can obtain those. There's links to things like the examinations, whether it's USMLE, ECFMG, there's links for them on those instructions at the very beginning before they ever start putting information in and before they submit. So we do give them a heads up on that in the application itself and on our website.
Thank you. One further question. When was the last time the licensing fee was increased?
Sarah Bradley, Deputy Executive Director for the record. Right now, the cap is set at $800 for it's a 2-year period. That is the max that can be charged. And then it had gone down for a short period, and recently the board voted to increase it back to the $800 within the last year. But that cap has been set in the statute for quite some time. And I apologize. I believe it's quite a while. Here we go, fees. Looks like that was, the statute was updated more recently, but I'd have to take a minute to find it, although I don't know if LCB staff has it more quickly than me.
We'll go ahead and review that as we're doing our questions. Last question from me, and then hopefully our committee members have taken their time to figure out what they're going to ask. In the presentation, it was mentioned that a lot of the applications are done at the same period of time. Is there a requirement that has to be done by a certain date, and is that an NRS? Or I think you understand the reason why I'm asking that. I don't know if that leads to the time frame of why the workload is always at the same time period of each year. And so is that is that date usually identified in our NRS, or is it specifically somewhere?
Yes, Sarah Bradley, Deputy Executive Director for the record. Yes, the June 30th renewal date for physicians, and I believe physician assistants is in the NRS. I believe the other license types are in the regulations, and I think we did it to match that. And then as far as the resident renewal, the NRS says that the resident license is good for 1 year. And because of the way the programs operate, and I think we heard that earlier today, they start in July. That's the time frame for them when people are graduating. And so that's the time frame for them. So that's why that one is.
Great. Any Dr. Spiritos, did you want to say something? Nope.
I was just going to add, when we looked at the fee schedule, I believe that fee has been set, it's been in place for 20 years plus.
I don't have it.
And I don't have the exact dates, but when we looked at it briefly at one of our meetings, that's what we had identified.
Oh, I'm seeing it here. It looks like Sarah Bradley, Deputy Executive Director for the record. I was looking at 2003 and it was $600. So it was after that. However, I just saw it. Yeah, it looks like, I'm sorry, I'm looking on my phone for this and I should have had this.
We can certainly, if it's easier just to follow up, I mean, I'm sure we can, just in the interest of time, I want to make sure that committee members have their opportunity to contribute, but we can certainly circle back with this question and just make sure the figure is right. The reason why I was asking it is obviously we've noticed the rise of inflation, and so perhaps it might be time to relook at what the fee structure looks like, and especially when it comes to providing you the right infrastructure and support. Okay. And that's why I think it's important for us to have this presentation, at least for now. Let's go with questions. Solomon Nguyen.
Thank you, Mr. Chair. Just wanted to, again, thank you for coming. I know that was a lot of information that you provided, so thank you for taking the time to do that. What caught my attention right away is that timeline between the compact licensing time versus the non-compact licensing time. It was a very big gap in between. So I know that your staff increase was very recent, Ms. Bradley, in terms of having 3.5 FTE added in January of 23. But, I guess my question is, like, what happens, number one, between the compact versus non-compact in terms of the length of time for getting it done? And then also, if that's the case, where there's such it's 3 times the amount, right? So what if that person comes in through the renewal period, right? When you have to deal with the rest of the world being renewed, does that timeline even exaggerate to a longer wait time? So those are kind of where I'm going with this time frame on the efficiency part.
Sure. Sarah Bradley, Deputy Executive Director for the record. That's why we said 1 to 3 business days on average, because there are factors that can extend that compact licensee being issued. However, under normal circumstances, it's within a matter of just a couple business days. Because what happens, the difference is, just to help you understand, when someone comes through the compact, they have to have a state of principal licensure, and that's one of those member states. That state has already vetted everything that we need. So literally, somebody, let's say, that's licensed in Texas, I'm going to use because they're a newer example. Someone licensed in Texas wants to come to Nevada. Texas has already vetted everything. For somebody to actually designate Texas as a state of principal licensure, all of the verifications, everything's done. We get a letter from Texas that says, please license Dr. Jones. And basically, that's our process. I mean, we receive that and we go ahead and process that as quickly as we can. So it speeds up. We don't need verifications of graduate school, things like that. We still do require state-specific requirements, which are identity documents, things like that. But actually, according to the rules of the compact, 1 to 3 business days is what we have to do. That's just the rule. And so we make sure we do it. Sometimes we are waiting on documents from them, state-specific documents, but they still get their license.
So the 45 days that you listed on the presentation, is that, you said that's an average, right?
Sorry, 45 days, that was the 2024 number?
This is one of the earlier slides.
Yeah, so the licensing times in 2023, I don't know, I had 86 days average for medical doctors. That includes everyone, compact, non-compact. And then I think you can see that the improvements we've made are increasing the time decreasing the time. Gosh, that was the wrong way. Because if you look at, it's 49 days now. So it's gone down from 86 to 49 because we are requesting fewer documents, I think. Again, the legislative audit showed 75% of it was gathering information. If they have to gather less, then they're getting licensed quicker. So yeah, 49 days as of the end of February, and that was including everyone, both traditional and compact. We don't give you the average for the compact because we know it's 1 to 3 business days.
Okay. Yeah, I just want to make sure I was clear on that one. So the 49 days you're referring to is just for the entire renewal period from when you do June 30th, or this is a year-round average?
That is January and February of this year, the average time for a physician. So anyone that was licensed starting January 1 to February 29, the average time for them from when they hit submit to when they got their license was 49 days. For physicians. And so that's just 2 months. But I think we are really excited about that number because we're working hard to bring it down. And last year our total was 86. And so we've gone down quite a bit. And I'm hopeful that we'll continue to go down as we, continue to process applications.
So what is the gold standard?
I guess I would say as fast as possible, which is I think what you would all say. I do think it's going to take time for us to process. But if you look here, the fastest licensing time, not through the compact, was 15 days. So that meant that person hit submit, their license specialist reached out to them and said, here's your packet, please get your fingerprints, et cetera. And then that person responded really quickly and that person got their license within 15 days. So to me, maybe that's our gold standard. I don't know. That's the fastest we've done it in the last 2 months. And again, a lot of that was probably that person had their transcripts, because applicants can get things ready ahead of time. So if they have everything gathered, like when the chair was mentioning earlier, a new grad might be really diligent and careful and they've been gathering these documents. They upload it, they hit submit. They could be licensed in 15 days.
Thank you.
Thank you so much. Assemblyman Hibbets.
Thank you. What is the cost of the license application?
So Sarah Bradley, Deputy Executive Director, for the record. I'm going to ask Ms. Lynn to take that question for me. I don't want to misstate.
Corey Lynn for the record. So at the beginning of the process, they pay an application fee. For physician unlimited license is $600 plus the background check fee. And then once their application is completed and their application's approved, they have a registration fee, which is their licensure fee, and that's $800.
And just Sarah Bradley, Deputy Executive Director, for the record, the background fee is $75. So it's $675 to start the process, and then once they're approved, $800, and that's for the next 2 years of practice.
And is the application fee, is that applied to the licensing fee, or is it $600 for the application, $75 for the background, and then also $800 for the license?
Yes. So the total that they would pay if they were at the start of the biennium would be that $1,475 would be the total. And that gets them their application processed and then 2 years of practice. And so they wouldn't have to pay again until 2 more years. The reason I say start of the biennium is we do prorate the registration fee depending on where they are because we want to try to be fair. So we don't take the full $800 if they're applying, later. So for example, it's March right now of 2024. Our next renewal is 2025. So we're still in the first part. But once we pass into July this year, then we'll start charging less for the registration fee.
Okay. And is the application fee, is that set in statute, or is that an arbitrary thing made up by the
No, that is a statute. And again, it's NRS chapter. Sarah Bradley, Deputy Executive Director, for the record. It's NRS 630.268. That's where all the fees are in. And I believe the legislature sets a maximum both for the application and the registration fee as well.
So it could be less.
It could. I don't recall if 600. I think the max for the application fee is 800, if I'm remembering correctly, and hopefully Mr. Robbins can correct me if I'm wrong. I believe it's 800 max for the application and 800 max for the registration, and we charge 6 and 8.
Okay, thank you.
Assemblywoman Brown, ma'am.
Thank you, Chair. Thank you, Ms. Bradley, for that presentation. My question is relative to the applications that are waiting for payment. Your presentation noted that there are 48, right, in your snapshot. And I'm curious to know, so I'm confused. Let's just start there. Initially, you said that we didn't know they were there until they made payment and hit send. But then in your presentation, you said there are 48 applicants that are waiting for payment. How does that happen? And how do we know they're there? And do we follow up with them?
So Sarah Bradley, Deputy Executive Director, for the record, and I apologize. I think there's a little confusion there. There's the application fee, and they have to pay that at the start, and that's when we know their application is pending. The 5 applications that are complete, waiting for the 48 that are approved, I apologize, 48 that are approved, waiting for payment, those are people that we've told, your application is approved, please pay your registration fee so your license can be issued. So we have them pay at the start the application fee. We work on their application, and then at the end, we say, please pay your registration fee so that they can actually get their license number. And they get emails right when it's done, and then I know that staff follows up. I want to say they have a little checklist, and Ms. Lynn can correct me, but I believe they follow up at least every week, but I'm not certain on that.
Thank you for that clarification. That was very helpful. And I just want to make sure that I'm really clear. The folks that are coming to us through the compact, it's the same fees for licensure as if you're going to start just a Nevada license. Is that correct?
I believe it is the same fees. Sarah Bradley, Deputy Executive Director, for the record.
Let's go to Senator Nguyen.
Thank you. I have a question. All the licensing, is it on a rolling basis based on your admission, or are they all at the same exact time?
Sarah Bradley, Deputy Executive Director, for the record. If your question, and I'm sorry if I'm misunderstanding, is how are we getting applications in? I'd say applications for new licenses come in on a rolling basis.
But then once you are on a rolling basis, you had said something about prorating it based on that.
Yes.
So if you were to, is everyone ever, like, once you're in there, is the renewal all at the same time?
All licensees renew. They have to submit their renewal by June 30th of the odd year. So the next renewal for us is June 30th of next year. So all 14,000 licensees will renew on June 30th of next year, yes. And we prorate the fee because obviously, as I just said, they're coming in on a rolling basis. And so it wouldn't be fair to charge someone for the full 2 years if they're not going to use their license for the full 2 years.
Is it in statute that they're all like on the same like renewal thing, or is that just a part of your process?
NRS Chapter 630 lays out the requirements for the renewal for the physicians. And I believe the physician assistants on June 30th. I know that I just did the regulations for anesthesiologist assistants. We actually added the June 30th date there because since that's when everyone else is. And the other 2 profession types, I don't recall off the top of my head exactly when they are because some of them were created in reg more than statute, if that makes sense. But I know physicians is in the NRS.
And how many doctors, physicians, assistants, all the people that you are responsible for renewing this license, how many individuals are there?
So there's just over 14,000 of all types.
And they're all coming in on that same...
On June 30th of the odd year, yes. We start...
Would it be helpful to have it on a rolling basis? Because it seems like you're doing all of your work in that same like time period.
It's hard to say. And what I mean by that is we would have to change a lot of processes. And so it might be a bumpy start if we were to do it. I know that we do bring in a couple seasonal people to help. I mean, so we have some staffing that we do to try to help with that. But yeah, I mean, right now our process is written that way. So we'd be some changes and that might cause some hiccups for us. But I understand what you're saying. And I could have Ms. Lynn speak to this if she wants to add anything.
Just doesn't seem like it's it seems like it's concentrated work to the point where you're having to hire outside people to come in because all 14,000 are there. And then you're backdating and prorating new licensees because they're probably coming out of their programs in the fall.
Well, again, Sarah Bradley, Deputy Executive Director, for the record. I do think online renewals make some of the renewal process easier. I'm not saying that it doesn't require human review, but I do know that at least some of it is sort of processed through the ordinary course. And I think the biggest staff time is people having a hard time logging into their portal and logging in, because sometimes, as you can imagine, people forget their password, things like that. So we get a lot of calls, and so there's a lot of communication, but we're not processing a lot of paper like we used to. And then I will say that, I had my thought, sorry, I apologize. I just think that it would be a big change to do it. I'm not saying that it wouldn't be wise. It's just hard to say how that would impact us. Our licensing vendor would also have to be on board with that. And I think one of the things that perhaps is easier is everyone does it at the same time, so there's no confusion about when you're due, where if everyone had a varying date, if somebody called and said, when does my license expire, the answer wouldn't be the same. So I don't know how it would work. I know other boards do exactly what you're saying. I know also there's a lot of boards that do the 1 year time frame.
And for the record, I am strong advocating for us to do it on your birthday, the same way that my driver's license. It's a good thing for us to remember. I don't think many of us will forget our birthdays, so maybe that's where we can start. Let's go to Northern Nevada. Senator Titus.
Thank you, Mr. Chair. First and foremost, I want to thank the medical board for the advancements you have done. Having served on the medical board many moons ago, you have really come leaps and bounds. I was first licensed in the state of Nevada July 1st of 1982. That's how long I've been a doctor, 42 years, having gone through this process every other year. And the fact that you have improve this process is dramatic as far as I'm concerned. So thank you. I do have several questions though and clarification just for all those who haven't gone through this license process, which I have just admitted I've done many times. We don't all just push the button on June 30th and apply for our license. They give us ample warning, your license due, you do it online. So it comes through a process. So not everything falls on that day. It's just when your license expires. So it truly isn't a push the button, everybody, 14,000 applications go in one time and shut the system down. So they are giving us ample warning. My question revolves around some of the data you gave us regarding this licensure, however, and you pointed out that on the days for the average licensing day is 49 days to licensure. And then you made the comment about you're no longer requiring direct source verification for clinical rotations in the for island and Caribbean schools. And that was one of the issues that we had a lot of American students go offshore that couldn't get into medical schools here. And so trying to find some of that data, I'm happy to see that you've loosened some of that. My question revolves around other foreign medical schools, however, and what's the time to license somebody that's gone to Oxford, somebody's gone somewhere in England or India or some of these other countries that do come to America, have had great training, and that was always a delay for us to get their license. What's that average time?
Sarah Bradley, Deputy Executive Director. I'll turn this over to Ms. Lynn. Thank you.
Thanks, Sarah. This is Corey Lynn for the record. It really depends. Since we do accept verifications direct source via email, that's helped a lot. So if it's coming from that .edu or whatever the foreign equivalent is directly from the school, we can accept it by email. The increase in use of FCVS packets, that's the Federation Credential Verification Service, which is under the Federation of State Medical Boards. It's very, very helpful for foreign medical grads to have that FCVS packet ready when they apply, and we can license them just as fast as an American graduate if they have that oftentimes. Sometimes it does take longer, especially if the graduation was from a school that maybe isn't, that's in a country that maybe isn't as willing to be forthcoming with the United States, that can be difficult. But we do work with the applicant to try to do what we can to get them licensed regardless. But there can be delays with that if we can't get that verification, because we need to know that they graduated and they legitimately went to school. It's so important that we obtain that direct source documentation so we can assure the public that we are vetting these physicians and that they're qualified regardless of where they went to school, whether that's in the United States or abroad. We do everything we can, but we do encourage graduates to obtain an FCVS packet, especially when they're in a foreign school, because then it's ready to go. It's already been direct source verified. We have the packet in front of us and it just flies through, and we don't have to worry about those delays that can occur.
Great, thank you. May I ask a couple more questions, Mr. Chair? They'll be quick.
Please proceed.
Thank you. So you mentioned that there's an application fee of $600 and then the every other year fee of $800. Does the applicant get that money back if they don't qualify?
It is in the law that the application fee is non-refundable, as well as the background check fee. We do refund the background check fee if they have not submitted fingerprints and had that background check completed. We refund that. And then the application fee is non-refundable. It is something that can be reviewed by the board if it's an extenuating circumstance. And so those refunds do sometimes occur.
Are we, and I although with all due respect, Mr. Chair, I don't, I think the $800 is plenty for me to spend every other year on our application or our licensing fee. And I'm just curious where we are compared to other states. And have you looked at what other states charge for their medical license? What I'm getting at is, are we high? Are we low? Because we certainly don't want docs not coming here because we charge too much.
This is Sarah Bradley, Deputy Executive Director, for the record. I did do some research on that back in, I want to say it was 2020, for one of the interim committees. I have not updated that research, though, since that 2020. I'd be glad to share what I have, but I think it probably should be updated. I know that's the last comparison numbers that I believe we put together for that.
So where were we when you did that comparison?
So Sarah Bradley, Deputy Executive Director, for the record. I guess I would say there's some states were higher than and some states were lower than. I guess I would say some of the states that were higher than are states with umbrella boards and different structures with regard to their licensing and their board structures. I think as far as boards similar to ours, we may have been $100 more or $100 less. I don't recall us being totally, on our own. I have heard that the state of California has raised their fees, as well as the state of Washington in recent years, perhaps response to, budget concerns by everybody. My understanding is maybe the picture might even look different than it did back in 2020. So and just for the record, I'd started with the board in November of 2019. So I believe it was just prior to COVID that I did that research. So I'm not sure how it would shake out today.
Is your board just all fee-based? Is that how you operate? Or do you have, I know this is a policy committee, but again, we've been talking about cost. And so are you fee-based for your board 100%, or do you also have some state budget added?
Sarah Bradley, Deputy Executive Director, for the record. We are funded by licensing fees. So we are funded by the application fee and the biennium renewal fees for all of our licenses. We also sometimes get cost reimbursement for disciplinary cases, the time that we spend on those cases, but any fine monies that we collect, we do send to the general fund. So it's just those other forms that provide our budget.
And final question, and it's more of actually a comment and a thank you, kind of a thank you. So thank you for bringing up the onerous mandates that they have been continually every session putting on physicians about mandatory CME. But I want to know, when I was vehemently protesting many of these CME requirements, pointing out exactly what you pointed out today, that we already have to get 20 20 CMEs a year, that by these additional mandates, we can't even do the ones that we really need to do, which is all about like diabetes and cardiovascular disease, et cetera. And for me as a long-term care medical director, the stuff I have to do for my aging population, why weren't you at the table when all these CMEs were being passed? I want to know, because you weren't in the audience, I don't think, when I was protesting. And I guess that was just more of a comment than a question. So thank you very much for pointing that out, though, and would love to work with you folks on trying to clean up some of our CME regulations. And again, thank you for the presentation today. It actually, you've come a very long way, and I appreciate what you're doing.
Thank you, Senator Titus. You don't have to answer that question. I know that I interacted with many physicians during the processes when those bills came forward, but I appreciate those questions. Let's go to Assemblyman Gray.
Thank you, Mr. Chair. And I'm going to dovetail into real quick what Senator Titus had mentioned about CMEs going into the potential BDRs. 2 hours on stigma, discrimination, and unrecognized bias towards persons who have or acquired HIV or risk of acquiring HIV. Why are we singling out one disease? I mean, honestly, when I worked in the ER and other places in EMS, I was more afraid of getting Hep C in a lot of cases. And so, I mean, I think we've all learned, especially this day and age, we treat every patient the same, universal precautions. You know, maybe if they're a regular patient of yours and you're working, family practice or something, but again, I mean, additional education that really doesn't, I don't think it really serves a purpose, but you don't need to, I mean, unless there's an answer for that, I don't know. I mean, it just seems like feel good legislation.
Mr. Chairman,
I can go ahead and answer that question really quickly. Assemblyman, a lot of the provisions, as they mentioned, are guided, of course, through the laws that are implemented and have been passed and signed by the governor and passed by the legislature. And so I think what you're seeing is a culmination of multi-year initiatives. And now there's a consideration of, does this make sense for all specialties or entities? And maybe they do, maybe they don't. And so I think that's kind of the review process that we're going through right now.
I guess my point being is that, I mean, any caregiver can have a bias towards any patient with any given disease. So anyway, all right, couple more real quick ones, if you don't mind, sir.
Please proceed.
Thank you. Average licensing times, including IMLC, 49 days. What is it without the IMLC? I mean, I have, if you're telling us it's 1 to 3 days for the IMLC, how is that, impacting that? I mean, it seems like it could artificially lower it quite a bit.
Sarah Bradley, Deputy Executive Director. I'm hoping Ms. Lynn has that. Otherwise, I believe I have it in my email, if I could just look that up.
Corey Lynn for the record, Sarah. I do not have that with me, but if you have it in your email, that would be helpful.
If you give me 1 second, I can find that. I don't know if you have other questions, and I'll find it and then let you know.
Yeah, I do have one other question, which is kind of interesting to me as well. Accept a notarized copy of identity document rather than applicant mailing original documents. For the life of me, I'm running this through my head. What is a notarized copy of an identity document? Is that something you guys provide? Do they have to sign in front of a notary? Because a notary can't notarize a birth certificate. They can't notarize anything that they didn't see signed. And an individual doesn't sign their birth certificate. So I'm just wondering what you guys are after there. Is it supposed to be a certified copy?
Corey Lynn for the record. So what we did was we mirrored the Federation of State Medical Boards and how they do it. And so the document itself is not notarized. The applicant is presenting the original document to the notary, and the notary is attesting that they saw it on a certificate of identification. And then that notarized certificate of identification, along with a photocopy of the document they viewed, is sent to the board.
Okay, so I mean, maybe that should be cleared up in here. It's a notarized attestation.
Correct.
Because that made no sense to me at all. So, okay, yeah, if you could get me the average without the IMLC, I would really appreciate it. My gut feeling is it's quite a bit higher than that 49 days. And Senator Oñate, that would be my last question.
If I may.
Please proceed, Dr. Spiritos.
Nick Spiritos for the record. I think the Senator is correct. That number will be prolonged, obviously, if the IMLC number is so short. But I also think what we should be emphasizing here are the changes that have been made, as Senator Titus pointed out. There have been a number of changes made in the last 12 to 18 months, but certainly over the last 6 months, that have been made by the board to streamline the procedure, whether it's through the use of IT or other methods of reducing the number of requirements, the number of years that we're going back to. I think the real test of this will be 6 months for a year or to a year from now, how well the board's performed in terms of reducing that number of days. I think that's the real question here, because I don't think it's a fair measure that we've made all these changes and then to be looking at it over the last 60 days or 90 days. I think whatever those numbers are, they're certainly improved. And what I would say is, my guess is, not my guess, it would be, I would think for sure those numbers would be even shorter after these changes have been implemented. I'd also like to comment in terms of foreign medical schools. Understand there are about 150 medical schools in the U.S., maybe 155, somewhere in that range. There are over 700 medical schools in India, just as an example. And trying to make sure that you're getting accurate information from 700 schools scattered throughout India has proven over time to be quite difficult, just as one example. Thank you.
So this is Sarah Bradley, Deputy Executive Director. If I may, Mr. Chair, answer the question. And I apologize, I don't have it for 2024, but if you want to compare it for 2023. So for 2023, we have 86 days as the average, including IMLC. It's 168 days, not including IMLC. And then the fastest non-IMLC was the 22. So it looks like the number goes down about half if we add the IMLC in. And then for 2024, I don't believe we've had that calculated yet. So what we have right now is the 49 average days in 2024. But we will have updated numbers, and we're glad to give you updated numbers as you request. So thank you.
Thank you so much. I believe we have reached the end of this presentation item, and so I don't have any further comments or questions. I do want to just say that we're open, at least from the committee side, to review and support your infrastructure. We want to make, as we mentioned, I think there's a common theme of making sure that as we get doctors and we fill these gaps, that our state has the resources equipped to make sure that these processes are fast and efficient. And so I just want to thank you for not only answering our questions, but also providing us the data that we needed to also understand the process and how can we help essentially for all of you. I don't know if you have any other closing comments or.
In closing, I would just say on the last side, Sarah Bradley, Deputy Executive Director, we do have our website and our email, and so please contact us if you have questions. We'd be glad to answer them. And it sounds like Mr. Clark has something.
Thank you for the record, Tom Clark. I do not. They've covered it quite well. I am always available if you have any questions or comments on any of the issues that you've heard today or have questions going forward. I would like to say Assemblyman Nguyen carried our administrative cleanup bill last session. As a freshman, he did a phenomenal job, and we did make some really nice changes there, one of which was we increased the fees or the fines that are implemented by the board, but instead of those resources going to the general fund, they now go to the state treasurer, and those resources are used to help students pay down debt, help folks that want to practice in the rural parts of the state, and that kind of thing. So thank you, Mr. Chair.
Corey Lynn, for the record, may I make a comment? I actually didn't realize, Sarah, I apologize. I did have another licensing number that could be helpful. So it was an average license time since the new procedures were implemented. That 168 days, I believe Sarah said, was including the time period before these new procedures were implemented. So since the new procedures were implemented, we had a 95-day number, which included some of the more difficult files, say undisclosed malpractice, files that had to stay open for board appearances, we didn't filter those out. And it was still down to 95 days from that 168 without including the compact numbers.
Great, thank you so much. As I mentioned, we
Senator?
we do have to move on
Excuse
to
Senator?
Dr. O.
Yeah, sorry, do you mind if I ask a question?
Just one question because we do have other presenters
Yes.
that might have to leave. So please make it quick.
Quick question. Yeah, so thank you for speeding things up and all these changes, and it's great. And it's also impressive how low the rejection rate is. You said only 1 out of about 2,000 people last year, you actually ended up denying a license. So what I'm wondering is, with the fact that it seems like people who are applying are actually qualified, and a lot of this information is available electronically, whether you can do a quick screen, and if there aren't, with whatever databases are out there, whatever they submit, do a quick screen, and if there's not a red flag, they're not from one of the 700 medical schools where you can't get good information from an overseas country, and there's nothing else that's a red flag, you could grant a provisional license, and then, they'd have to confirm everything to make it a regular license. Is that something that could speed up the process?
This is Sarah Bradley, Deputy Executive Director, for the record. I have a preliminary comment, and then I'll turn it over to Ms. Lynn. The denials are applications that are denied. I will say there's a larger number of people who withdraw their applications during the process, and denials are reportable, and denials, I guess, are a different thing, but there are a number of people who apply and realize that they don't meet the qualifications or there's other issues, and they'll withdraw their application rather than be denied because they don't want that reported to the National Practitioner Data Bank as well as other entities. And I don't know if Ms. Lynn has anything to add on that.
Corey Lynn, for the record, Sarah's correct on that. If someone's looking like they're going to be ineligible, sometimes we can tell right away they're ineligible, which we talk to them about that at the beginning of the process and give them the options, or if there isn't an option, then they can withdraw their application. And then if something comes up later in the process, they can choose to appear before the board and kind of try their chances with them, or sometimes they just withdraw rather than take the chance of that denial.
And then Sarah Bradley, Deputy Executive Director for the board. As far as the provisional license goes, I'm not sure. I feel like, and we can talk about it more maybe, we don't hold the license up for things except for what's not submitted. And so if perhaps there was a list of items that the legislature believed, we don't need to verify before that. I mean, at this moment, it's not something that we do or have processed for or have thought about in that much detail. I just do want to say, though, that once the application is complete and everything has been gathered, the license is issued within the next business day after payment. So once they pay that registration fee, they get their license. So any delay that is there is either them not sending or us not receiving documents that we need. We don't hold up licensure for fingerprints. So there are times that people do submit their fingerprints toward the end of the process, and we don't wait for those results. So we've done everything we can to speed it up. And I guess we'd wait for direction from you on other things you'd like to see.
Great. Thank you so much. We'll go ahead and close out this agenda item, and we thank you all for participating. And of course, we ask our committee members if they have any further questions to obviously take them offline so that we can continue on with our process. I recognize that there is one presenter that may have to leave shortly, and so I'm going to have to change the order of the agenda items again. So we'll go ahead and move on to agenda item number 7, a presentation on the impacts of healthcare consolidation. And so if our speakers are ready, if you can please make your way forward, and we'll give you some time to set up. Virtually, we have representatives from Families USA. We have Ms. Jane Sheehan, who is the Deputy Senior Director of Government Relations. And we also have representatives, we will hear testimony today on the issue of of healthcare consolidation and how it impacts local markets. We have Jesus, who is the president of the Culinary Health Fund, and Mason Van Houweling, who is the CEO of University Medical Center. So please begin when you're ready.
Good afternoon, Mr. Chair. I'm Jesus Higuera, for the record. I'm the president of the Culinary Health Fund. Culinary Health Fund is a nonprofit labor management trust fund providing care for 130,000 lives in the Las Vegas geography. We, as a payer, pay approximately $600 million a year on benefits. We're also part of the coalition, the Health Services Coalition, which is a 25-member coalition negotiating hospital contracts, and we represent over 250,000 lives in the Las Vegas region. Part of the Culinary Health Fund of our vision is to provide quality health care, and part of our vision is building out medical centers. We currently have 2. Our first on Nellis opened back in 2017, and our second opened May of 2023. Our hope is by 2026 to have 4 of these medical centers up and running. And we try and provide as many services as we can to our members and their dependents. And it's a way to manage our quality and also our cost of benefits. In our centers, we provide primary care, pediatric care, dental care, eye care, mental health counseling. We have pharmacies which are free from any copayment, physical therapy and acupuncture, laboratory, wellness classes, and all of this is provided with zero copayment or very little copayment. Nevada has made important transparency steps to begin to address healthcare consolidation, but more needs to be done. In 2021, Senators Lang and Donati sponsored SB 329 to address the anti-competitive contracting practices, which also required hospitals and physician groups notify the Department of Health and Human Services within 60 days of a merger or acquisition. The state is also responsible for documenting these transactions and reporting them. In that same session, the legislature also passed AB 278, sponsored by Assemblywoman Duran, requiring physicians to list their employer on initial licensing and renewals. Compliance to us is quite not clear just yet. The research literature shows that nationally, private equity acquisitions in healthcare are accelerating and are associated with higher costs, workforce cuts, and mixed to harmful impacts on quality. A study published last week in Health Affairs found that private equity acquisitions in physician practices grew 7-fold from 2012 to 2021. Same study showed that private equity share of physician practices in 10 specialties was 10 to 30% of the Reno and Las Vegas metro areas in 2021. Private equity clearly has a significant piece of the state's healthcare market, and we expect it is continuing to grow, but there is not good understanding of its footprint or impact on the community. As participants in the healthcare market, purchasing services for our participants, we have seen major consolidation in the ownership of physician practices, the expansion of freestanding EDs, and hospitals hiring doctors. This has led to reduced competition, canceled contracts, higher price demands or costs, delayed care, and physicians locked into non-compete agreements, forcing them to leave the community if they want to work independently or in another practice. Next slide. This slide has a lot, and what I would say is not everything is clearly, this is not a complete list of private equity movement in Nevada, but it does highlight some of the areas. As you can see, private equity is involved in air and ground ambulance, ambulatory surgery centers, hospitals, long-term acute care, behavioral health, physician groups, including anesthesia, dermatology, radiology, physician staffing companies, and urgent cares. Our experience at the culinary with private equity interference was one that I can share with all of you that happened recently. We had a capitated contract with a local radiology provider, probably the largest in the city. They got acquired by Rad Partners, which is a private equity group, and immediately things changed for us. Part of the capitated agreement involved access to care, obviously, but also quality metrics that needed to be reported out. Quickly thereafter, we realized they were not meeting quality and we could not get access for our members. It seemed that every time a member called for an appointment, they were treated as third-class citizen. And that wasn't the case before.